Very good. Thank you. All set then, Karen?
All set.
Good morning, everyone, and welcome to this morning's hearing. It's a public hearing. We'll be going over 4 bills in the following order: 1841, 1758, 1848, and then 1792. Appreciate your being here. You can see us on the YouTube channel for this committee. If you'll go to the legislative website and use the drop-down, select HHS, Health and Human Services, you'll be able to find the link. Everything we do is recorded, so you can go back and look at portions that you've missed. We've already had some unplanned technical glitches, and there are more in our future, so please bear with us as this happens. The committee will keep its cell phones off and themselves on mute, and we won't be doing anything in the chat. It isn't related to the flow. So if you're testifying, everybody will have the bill that's being heard, so they need to be specific to that. Please rename yourself as you can to let us identify yourself accurately. And when you move from attending to participant, you have to click on something. It feels like you're being lost, but you're not. Hang in there. When we're done, when you're done with your testimony, please go to the YouTube channel and watch if you are planning to do so from there. Written testimony can be submitted anytime electronically or by mail up until the work session. And the chat function has been turned off for those who are waiting to testify. Testifying is limited to 3 minutes. After the bill is introduced, that's about 1.5 pages of typed material. And if you're not done in the 3-minute window, we'd ask you to conclude and submit the rest of your testimony in writing. Committee members are invited to ask clarifying questions about testimony after you're finished. So with that, I'll have the committee introduce themselves, and I'll turn it over to my chair for right now.
Thank you, Mr. Chair. So we will start around the virtual horseshoe with Representative Zager.
Thank you, Madam Chair. Good morning, everyone. Sam Zager, District 41 in Portland.
Representative Lemelin.
Good morning, everyone. I'm State Representative Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
And Representative Perry.
Good morning. I'm Representative Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Bering, Calais, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Javner.
Good morning. I'm Representative Kathy Javner. I represent House District 141, which is located in Penobscot and Washington counties.
Looking for Representative Connor. Not seeing him this morning. Representative Craven.
Thank you, Madam Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Good morning. And Representative Madigan.
Thank you, Madam Chair. Good morning. I'm Colleen Madigan. I represent House District 110, which is half of Waterville and a little bit of Oakland.
I believe, let's see, Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Deske.
I believe Senator Moore was going to be on the phone on her journey in, and I'm not seeing her. Karen is, no, we'll have Marianne introduce herself when she arrives. Senator Claxton.
With respect to Senator Moore, she may be calling in, so we may be getting a phone number and renaming it for her name.
Sounds good.
Good morning. I'm Ned Claxton. I'm the Senate representative from District 20, which includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. And I'm the Senate Chair.
And I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott, where I live, parts of Kittery and South Berwick. I am the House Chair. I will turn it back to my Senate co-chair because I am introducing the first bill on our agenda today.
So with that in mind, we can begin with the process of hearing LD 1841. And I defer to Representative Meyer to introduce 1841.
Yes, thank you, Mr. Chair. I am Representative Michelle Meyer, serving House District 2. I was asked to sponsor 1841, which is a resolve regarding legislative review of portions of Chapter 283, Newborn Blood Spot Screening Rule, Section 14, a major substantive rule of the Department of Health and Human Services, Maine Center for Disease Control and Prevention, LD 1841. And with that, I will turn over for testimony to Holly Richards of Maine CDC. Is Ms. Richards with us? Karen? Here she is.
There she is. Welcome, Holly Richards.
Can you guys hear me?
We can. We
Okay.
can't see you, but we're understanding that
don't-
you're going to testify about LD 1841.
Yes. And I'm sorry, I don't know why my video is on. Good morning, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Holly Richards, and I am the Newborn Screening Program Manager in the Division of Disease Prevention, Maternal and Child Health Programs. I'm here today to provide testimony on behalf of the Maine Center for Disease Control and Prevention, and will be speaking in support of LD 1841. This resolve provides the legislative review of portions of Chapter 283, Newborn Blood Spot Screening Rule, a rule administered by the Department of Health and Human Services, Maine Center for Disease Control and Prevention. On March 11, 2021, the department adopted an emergency routine technical major substantive rule change to add conditions to the newborn blood spot screening panel and to require providers to pay an increased fee to support the costs associated with screening for additional conditions. These 4 conditions, MPS 1, Pompe, SMA, and XALD, were included in the subsequent routine technical rule change adopted by the department and effective June 1st, 2021. The major substantive provision in Section 14 of Rule Chapter 283 was provisionally adopted on May 19, 2021. And in accordance with 5 MSR Section 80543, this change to the filter paper fee may be in effect for up to 12 months or until the Maine legislature has completed its review. The department did not receive any public comments to the rule change. Pursuant to 22 MSR Section 1532, for all babies born in the state, Maine's Newborn Blood Spot Screening Program facilitates newborn screening for certain treatable congenital, genetic, and metabolic conditions. Babies with these conditions may look healthy at birth. However, if not treated, these conditions can cause health problems such as intellectual disabilities, developmental delays, sickness, and even death. The health implications of newborn testing are critical. With early detection and appropriate treatment, health outcomes may improve and health problems may be reduced or prevented. The fee charged for the filter paper used for the blood spot screening panel is necessary to offset anticipated costs, including genetic clinic contracts, resource materials, follow-up services, and other programmatic operations. The emergency clause ensures there is no lapse in the fee collected. In summary, the Maine CDC supports this resolve and respectfully recommends that the committee approve the major substantive rule change as it is necessary in order to continue the increased fee that operates ongoing funding to support the conditions recently added to Maine's newborn blood spot screening panel. These additional conditions are consistent with the recommended universal screening panel, also known as the RESP, and to provide Maine families important testing, resources, referral services. The infrastructure in place provides screening services for all the listed conditions, and hospitals, birth centers, physicians, midwives, and other healthcare providers parties subject to Maine's newborn screening rule have adjusted to the $220 fee implemented in April of 2021. The department identified no other less costly method of achieving these changes, estimated to cost the department approximately an additional $500,000 in laboratory expenses. Thank you for your consideration of this matter and for the opportunity to provide testimony today. I can address any questions from the committee and am available to participate in a work session. Thank you.
Thank you for being here, Holly. Are there any questions of that testimony? I'm not seeing any, so thank you again for being here, Ms. Richards. And I don't see anybody else who would like to testify. If you do have something to offer on LD 1841, could you please put up your hand if you're in the attendees list, and we'll admit you. And not seeing any hands up. I think we can close. Oh, there's a hand up. Good morning, sir. How are you, Jeff Austin? Welcome.
Good morning, Senator Claxton, Representative Meyer, members of the committee. Should I begin now?
Please.
Okay. I'm here on behalf of the Maine Hospital Association to provide testimony neither for nor against. We have no objection to the bill, but I would note that the increase in the fee from $110 to $220 per birth is going to be borne by providers. I've provided you written testimony. In my written testimony, I quote the economic impact statement where it says, DHHS anticipates providers, predominantly hospitals, will pass along these costs to their consumers. As you may know, Medicaid is half of our consumers. So we need to pass along half of these costs back to Medicaid as the purchaser and consumer of these services. There is no way for us to do that except by coming to you and asking for this change to the rule, to their reimbursement rules, and then appropriation sufficient to cover the costs. It's going to be somewhere in the $500,000 to $600,000 range. We don't know exactly, but we do know exactly how much it is per birth. It's $110. So we would ask that you direct the department to amend its reimbursement rules to provide for an additional $110 per birth so that Medicaid picks up its share of the costs and we don't have to try to pass all of the costs over to the commercial market. Again, you have my written testimony. I'd be happy to take any questions.
Are there any questions of Mr. Austin? And apparently, I'll ask then, apparently the hospitals have been working under this arrangement for a while now already, correct? Because it was passed as an emergency rule. And is that 500,000 figure that you've cited, is that based on experience so far with the change in the charges?
No, it's a very crude estimate. My understanding is there's approximately 11 to 12,000 babies born per year. We believe roughly half of them are Medicaid. But of the 12,000, approximately 1,000 of those 12,000 are born in critical access hospitals. They have cost reimbursement, so they will automatically be covered. So knock the 12,000 down to 11,000. Half of 11,000 is roughly 5,500 times $110. Again, the gross estimate is almost irrelevant. We're not going to get paid more or less than we deserve. We're only asking for $110 per Medicaid birth. And if it turns out to be a lot of births, we'll get more money. If it turns out to be not so many births, we'll get less. But they should change their reimbursement manual to increase births at non-critical access hospitals by $110. Where else are we supposed to get this money?
Are there any other questions? Not seeing any. Thank you for being here.
Thank you. Appreciate it.
Have a good day. So I don't see any other hands up for, against, or neither for nor against. So now we can conclude the public hearing portion of our consideration of LD 1841. Yes, Representative Zager.
Thank you, Mr. Chair. I just, for the work session, wonder if we could get some comment from the department as far as how they, if and how they intend to account for the concern that Mr. Austin brought up in their next budget allocation request that they're going to be working on over the next year.
Any other requests of the analysts in anticipation of the work session? I'd also like to know, just to have it confirmed, what percentage of people have the blood spot test done. I understand that it's offered, but not mandated in most facilities. So if we can get a sense of the number of births that have those, number of births to main care patients specifically, that might help get the number a little closer to very accurate. Any other questions to go to Sam? All right. That being the case, then we can move to consideration of LD 1758, the public hearing portion of this bill, and that will be introduced by Representative Madigan, I understand.
Thank you, Mr. Chair. Good morning, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. I am Representative Colleen Madigan, and I represent part of Oakland and part of Waterville. I'm here this morning to present to you LD 1758, an act regarding access to telehealth behavioral health services during public health emergencies. LD 758 improves access to treatment and information sharing during this challenging time by providing that during a federal or state public health emergency, behavioral health providers can obtain consent through verbal, electronic, or written communications. Since the start of the COVID-19 pandemic, we have allowed these forms of consent. My bill simply ensures that behavioral health providers can continue to use these methods. This isn't any different than what has been happening in Maine, particularly in rural areas, where it is already more difficult to have in-person appointments. Existing best practices also say that any signature obtained for any reason, like a treatment plan, consent to treat, rights of recipients, should be documented, and the reason why a signature was obtained in a particular manner should be recorded. This change is a common sense codification of a practice that has worked for Maine throughout the pandemic. I'm happy to take any questions.
Thank you, Representative Madigan. Are there any questions for her? I don't see any. So thank you for introducing the bill. Next, we'll go alphabetical order is the way these things happen, by first name, to Ann Sedlak. Welcome and good morning.
Thank you so much. Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Ann Sedlak, and I'm associate at Preddy Flaherty. I am here to testify on behalf of our client, Teladoc Health, in favor of LD 1758, an act regarding access to telehealth behavioral health services during public health emergencies. Teladoc Health is one of the world's largest telehealth companies and has more than 50,000 clinicians, including more than 11,000 licensed therapists. It delivers healthcare in 175 countries and in more than 40 languages. And it partners with employers, hospitals, health systems, and more than 50 health insurance plans in all 50 states to transform healthcare delivery. For context, in Maine, Teladoc Health is offered as a benefit by over 2,200 Maine employers, covering over 138,000 people in the state. It has saved Mainers an average cost of $472 per visit, and in 2021 has saved over $2 million in redirection savings to Maine's healthcare system and patients. We believe that telehealth is a valuable tool in the practice of medicine and allows clinicians to reach more patients. It is a great social equalizer because regardless of race, gender, socioeconomic status, or geography, people can have access to the best treatment possible. Teladoc Health supports LD 1758 because it believes that artificial barriers to providing the people of Maine affordable and accessible behavioral health services need to be removed. Informed consent is a critical part of treatment. However, mandating that informed consent be provided in one form and one form only creates barriers to care. Many of the boards of licensure for healthcare in Maine have recently taken up rulemaking on telehealth to ensure streamlined virtual healthcare services for residents across the states. For example, the Board of Licensure in Medicine, Board of Osteopathic Licensure, and the Board of Nursing are currently working on a consolidated rulemaking on telehealth standards. And the Board of Social Work has a meeting this fall to discuss a rule on telehealth. And part of their discussion has been talking about informed consent. And they've considered that verbal consent is good as long as the clinician documents that consent. This proposed rules will hopefully be published for public comment in the spring. The work of these boards indicate the commitment to providing and ensuring safe, high-quality care via telehealth and not just in a public health emergency. The only thing that telehealth would like the committee to consider as they move into the work session is ensuring that the definition of a licensed facility is inclusive to all and not just those who have a brick and mortar facility located in Maine. We are committed to providing affordable services to Mainers, and not having a physical location is one of our cost-saving measures. However, just because we do not have a physical location does not mean that we are not committed to partnering with Maine clinicians who are located here. Thank you for your time, and thank you to Representative Madigan for bringing this bill forward. I'd be happy to answer any questions or provide any further information necessary for your work session.
Thank you for that. I see a question from Representative Craven.
Thank you, Mr. Chair. Thank you for your presentation. My question was whether or not somebody providing care outside the state of Maine, are they able to bill MaineCare for services, for telehealth services?
I'm not sure on that. I can definitely get back to you and send an email and let you know that question.
Any other questions? If you have something to offer, let's see, we're then going to hear from Molly Bogart. Welcome.
Good morning. My name is Molly Bogart. I'm the Director of Government Relations for the Department of Health and Human Services, and just wanted to testify briefly to let you know you have a letter from Director Probert in MaineCare. We are supportive of ensuring that folks can provide their consent in a variety of ways. We're just asking for one small language change. There's a may provide consent, and we're asking for a shall to ensure that statute continues to recognize that consent is required and that consent can be delivered in a number of ways. And so fully supportive of the intent, simply asking for that one language change, which is in your testimony from Director Probert, and we're happy to talk about that at the work session, or I'll answer any questions that I can right now. Thanks so much.
Thank you, Molly. Any questions for Molly? I'm not seeing any. So we also can hear from Sarah Calder. Welcome.
Good morning, Senator Claxton, Representative Meyer, and members of the committee. My name is Sarah Calder, and I'm the Director of Government Affairs at Maine Health, and I'm here to also testify in strong support of LD 1758. Since the start of the public health emergency, Maine Behavioral Healthcare, which is part of Maine Health, has made significant investments to meet our clients' needs in a setting and modality that works best for the client and their clinical needs. So while telehealth is used broadly across the Maine Health system, it has been incredibly important in meeting the needs of our behavioral health clients, and it's proven to be very effective for many clients with our no-show rates reduced and with high patient satisfaction scores. With 70% of our visits with clients now conducted over video or telephone, telehealth has also allowed us to expand our capacity and serve more Mainers in need of behavioral health care or substance use disorder treatment at a time when you've heard me say before, the need has never been greater. In fact, we've seen a 20% increase in the number of client visits each week compared to the time prior to the pandemic. And we're grateful to your support and the administration as you've supported the use of telehealth through MaineCare and commercial health plans. And as you've heard, the bill before you today just simply lifts the Maine Division of Licensing and Certification requirement that a provider collect written consent and instead allows for verbal consent to treat a behavioral health or substance use disorder client during a federally declared public health emergency. And I would note that MaineCare already allows for verbal consent not tied to a public health emergency, and that verbal consent must be documented in the patient's medical record. Many of our clients struggle with transportation. They don't have access to technology like a printer or scanner. And so for this vulnerable population, the simple process of coming into the office to provide a signature or scanning their signature can be a significant and unnecessary barrier to accessing care. A wet signature should not be the barrier to providing timely and effective care remotely to a vulnerable patient population that might otherwise not be able to get treatment without telehealth. And so with that, we would urge you to support temporarily allowing the collection of verbal consent to treat behavioral health and substance use disorder clients. And I would be happy to answer any questions that you have. And I would like to thank Representative Madigan for bringing this bill forward.
Thank you, Sarah. I'm looking for anybody else who would like to speak in support of this bill. I'm seeing a hand up. Can we bring in Lisa Harvey McPherson? And I will also bring over Senator Moore. Welcome, Ms. McPherson.
Yeah, good morning. Can you hear me okay?
We can.
Great. Good morning, Senator Claxton, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here today to speak in support of this bill on behalf of Northern Light Health, specifically Northern Light Acadia Hospital. Before the pandemic, Northern Light Acadia Hospital had a long history of providing telehealth behavioral health services. Individuals had the option of receiving services on our outpatient campus in Bangor or through telehealth in their home or in partnership with primary care providers. When the pandemic caused us all to rapidly transform our delivery system to access telehealth for a wide array of services, Acadia transitioned nearly 100% of our outpatient population to the telehealth service. It's been highly successful, and in fact, today, most of the behavioral health patients prefer the telehealth platform. And as a side note, we also provide telehealth behavioral health care in 17 emergency rooms in hospitals throughout the state of Maine. On May 26, the Maine Office of Behavioral Health issued a guidance to behavioral health providers regarding consent. And that guidance did include the flexibility to obtain verbal consent for services. The bill before you today codifies that policy into statute, allowing the option for verbal and other types of consent during a state or national declared emergency. And we're in full support of this. I do want to raise concern with Section A, the definition of a licensed facility in the bill. I believe the statutory definition refers to a licensed community mental health center or a licensed PNMI facility. I don't see a reference to a general medical hospital that provides outpatient mental health services or a psychiatric hospital that provides outpatient mental health services, both providing services by telehealth. So I asked the committee to seek a deeper clarification of exactly what facilities are included in the definition, the statutory definition in the bill, and make sure that general hospitals and psychiatric hospitals are also included. And with that, I welcome any questions that you have.
Thank you very much. Are there any questions? I don't see any. I don't see anybody else who'd like to testify for. Anybody who'd like to testify against, please put your hand up in the attendee list, or if you're neither for nor against. In the meantime, I'll give Senator Moore the opportunity of introducing herself if she can do so safely on the road.
Good morning. Thank you, Senator Claxton. I'm going to be very careful, cautiously, as I'm transversing across Route 9 over here. I am Marianne Moore, and I represent Senate District 6, which is all of Washington County, and I've got Winter Harbor, Sullivan, and Goldsboro in Hancock County as well.
Thank you. Travel safe. So I don't see more testimony that's being offered with respect to this bill. That being the case, we can conclude the public hearing portion and ask if there's any further direction to go to our analyst. Sam, was that specific enough, Lisa Harvey McPherson's request, that you can work with that? Okay. Any other requests of Sam on this bill?
Yeah, I have a question, and I guess the question is, and maybe that can be clarified, about an individual private practitioner who is not working within a facility, but is licensed in the state of Maine.
Yeah, the facility sounds like a bit of a challenge. Okay. All right. I'm not seeing anybody else who'd like to testify on this bill. So that being the case, we can move on to consideration of LD 1848. And again, I'll go to Representative Madigan to introduce the bill.
Thank you, Mr. Chair. Good morning, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. I'm Representative Colleen Madigan, and I represent part of Oakland and part of Waterville. I'm here this morning to present to you LD 1848, an act to increase the availability of assertive community treatment services. This bill is very simple. It just expands the definition of prescriber to include all the types of behavioral health professionals that are employed or can be employed on an assertive community treatment team. Physician's assistants, certified nurse practitioners can perform this job as well as a physician. The change would better utilize the availability of already trained and qualified professionals in the field for this critically needed work. Please remember that assertive community treatment is a multidisciplinary team that works 7 days a week, 24 hours a day with the clients they serve. Anything we can do to increase the availability of this service will better meet the needs of those Mainers who depend on these services. Thank you for your time, and I'm happy to take any questions you may have.
Do you have any questions, committee? I'm not seeing any. Thank you, Representative Madigan. And so we'll move to the next person testifying in support of this bill. That will bring us to Jessica Pollard. Welcome, Dr. Pollard.
Good morning.
Good morning.
So Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services, I'm Dr. Jessica Pollard, Director of the Office of Behavioral Health within the Department of Health and Human Services. I'm here today to introduce and speak in support of LD 1848, an act to increase availability of assertive community treatment services. We are very grateful to Representative Madigan for her commitment to ACT services and for introducing this bill on our behalf. LD 1848 seeks to enhance the ability of providers to deliver assertive community treatment, or ACT, by expanding the types of professionals who can comprise an ACT team. ACT is an evidence-based intensive community mental health service for individuals with serious and persistent mental illness, or SPMI, requiring providers to be available 24/7. Multidisciplinary ACT teams provide comprehensive services such as medication and case management, peer support, and employment support to those with SPMI via rigorous outreach and multiple face-to-face encounters each week. Currently, statute requires an ACT team to have a psychiatrist, registered nurse, certified rehabilitation counselor or certified employment specialist, a peer recovery specialist, and a substance use disorder counselor, and may include an occupational therapist, community-based mental health rehabilitation technician, psychologist, licensed clinical social worker, or licensed clinical professional counselor. Typically, such level of detail regarding staff and credentials is specified in rulemaking rather than statute. As you are likely aware, there's a shortage of psychiatrists in Maine and nationally. This is only anticipated to worsen as roughly 2/3 of psychiatrists are approaching retirement age this decade, with estimates being as high as a shortage of over 31,000 psychiatrists by 2024. As such, passing LD 1848 would provide flexibility for ACT teams to hire other qualified prescribers who can practice within the scope of their licensure, adding nurse practitioners and physician's assistants, thus broadening the applicant pool for prescriber positions and subsequently more opportunities for ACT teams to deliver services. Further, LD 1848 provides for a licensed practical nurse or LPN to fill the nursing role, in addition to the current RN credential and proposed nurse practitioner. Like figures for psychiatrists, the Bureau of Labor Statistics projects a continued shortfall of nurses as approximately 1/4 of the RNs in the United States nears retirement age. In September of 2021, the American Nursing Association asked the Federal Department of Health and Human Services to declare the nursing shortage a national crisis. Expanding the requirements for the nursing role on an ACT team to include the LPN credential will provide hiring flexibility necessary to staff this vital service for Mainers with SPMI. Thank you for your time and attention. We have received feedback and recognize there may be some language changes for the committee to consider, and we look forward to that conversation. I would be happy to answer any questions and to make myself available for a work session.
Thank you for your testimony and then for that offer. Are there any questions of the doctor at this point? Did those language suggestions, questions get transferred to us in some format that we're aware of them going into the work session?
I am not sure that they've been sent over. There was a little bit of miscommunication. We sent the wrong version to the revisor, so we are happy to work on fixing that. I'd have to check with Molly to see if we've sent them over yet.
So if you can update the testimony to reflect those questions that have been raised, then we'll have that to review before the work session. Thank you for that. Any other questions, concerns? Thank you for being here, Dr. Pollard. Have a good day. Next, we'll go to Kevin Voivodich.
Morning. Can you hear me okay?
We can.
Okay, thank you. Senator Claxton, Representative Meyer, members of the committee. My name is Kevin Voivodich. I'm a managing attorney at Disability Rights Maine, as well as one of the attorneys on the AMHI consent decree, and I'm here today in support of LD 1848. As Dr. Pollard talked about, this expands the statutory criteria, of who a prescriber can be and who can fulfill the nursing role in this bill. And I think this is an important bill because it recognizes that this change would be needed to expand ACT services. And it's an important service for community mental health services. It keeps individuals out of institutions, more restrictive environments. And it's really a key component of a community mental health system. So we really hope this expansion will help increase this critical community-based service. And we're pleased to support this bill, and let's get some more ACT teams in the community. So thank you very much, and appreciate your time.
I'm not seeing any questions, so thank you for that testimony. Thank you for being here. Next, we'll go to Simone Mallon for her testimony.
Good morning, Senator Claxton, Representative Meyer, and esteemed members of the Health and Human Services Committee. My name is Simone Mallon. I live in Winthrop, and I am the Executive Director of the Consumer Counsel System of Maine, which I'll remind you, because it's my first time this session before you, that we are put into Maine statute as an advisory body for state government and for the legislature around advice and the voice of people living with mental health challenges in public policy. We applaud the department and Representative Madigan for bringing this bill forward. It is no secret that there are many issues in Maine's mental health system today and many services that are in crisis. So anything that we can do as a community to broaden access to community-based services, which ACT is one of them, we highly support. We are very well aware of the shortages of psychiatrists. Last year, I knew the figure was around 80% of prescribing was done by nurse practitioners. So that really just underscores the need to make these changes to the statute so that it allows for both other prescribers and also broadens the nursing capacity as well. I would be remiss if I didn't bring up the fact that many ACT teams in Maine, the model also includes a peer support specialist. And I will tell you that often in the state of Maine, our ACT teams do not hire peer support specialists. So if we're going to fix the ACT service and bring on the members that are required and expand access, we really need to make sure that we're making sure that the teams are also including the other members that make it an evidence-based practice, including peer support. Our peers in Maine really want that part of the team to be available and act in the way that in their role as a peer support specialist and not as a case manager. So we highly support this bill and hope you also have at least some conversations about peer support and what we need to do to get to the place where they're required as per the evidence-based practice. And I thank you for your time and I vote you to ought to pass this bill. Thank you.
Thank you for that testimony. Are there any questions of Ms. Mallon? I don't see any. So I think that's the extent of those who wanted to testify in support. I don't see anybody who wants to testify against, but we do have Pam Cahill here to testify neither for nor against. Welcome. When you're unmuted, we want to hear what you, there we go.
Here we go. Thank you, Senator Claxton, Representative Meyer, and members of the committee. I'm sorry, my screen just went blank, but I'm assuming you can hear me. Is that correct? Hello?
We can hear you, Pam.
You can? Okay, great. Thank you. My name is Pam Cahill. I represent the Maine Nurse Practitioner Association, and I'm happy to be before you. Happy New Year, everyone. This is my first time this year testifying in live. As you know, there are more than 2,000 nurse practitioners licensed and practicing here in Maine. The Maine Nurse Practitioner Association is in full support of the intent of this legislation, certainly, which we think is, we appreciate the prescribing language, the expansion of the prescribing language, and the inclusion of LPNs on the ACT teams. We're testifying in the neither for nor against category because we do have concerns, and maybe the concerns are what Dr. Paula talked about a little bit, with the language in lines 22 and 24, which says a licensed practical nurse may be included on an ACT team in lieu of a registered nurse if the prescriber is not a certified nurse practitioner. That to us, that's complicated and gives us a little bit of pause about that, about a future interpretation of that. I have spoken with Ms. Bogart at the department. She assures me the intent of the bill is not to in any way disenfranchise or not include nurse practitioners as a member of these ACT teams, but we wanted to get that out. Frankly, I think, I guess I can talk with Sam about this, but if you wanted to amend the language just to say a licensed practical nurse may be included on an ACT team, period, that might satisfy the situations and achieve the department's goal and make us less nervous. So on behalf of the Nurse Practitioners Association, I'm sure we can work out this, and I look forward to a work session and happy to be available. I did not submit my written testimony, but I will.
Thank you for that. Are there any questions of Pam Cahill? I don't see any. So thank you for your testimony. Sam, does that give you enough to work with? The questions? Yeah. Okay. So not seeing anybody else who would like to testify neither for nor against. Oh, there's a hand up. Sarah Calder has her hand up. Is that because you'd like to testify, Ms. Calder? Welcome.
Yes, please. Thank you. Hi again, Senator Claxton, Representative Meyer, and members of the committee. My name is Sarah Calder, and I am here to testify neither for nor against this legislation. We strongly support increasing ACT services, and we believe that psychiatry must be available to support any ACT team, as has been shown in the evidence-based care model. As you've heard from Simone, our behavioral health system is in crisis. We are seeing that acutely in our hospital emergency departments. On any given day, up to half of Maine Health ED beds are filled with patients awaiting behavioral health beds. So let me just put this into context for you. When we spoke with you last session about the ACT bill and other behavioral health bills, we averaged 25 behavioral health patients in our EDs on any given day. And that length of stay for these patients is increasing and is oftentimes 3 to 6 times longer than those for medical patients. We're grateful to this committee, to the legislature, and to the administration for the significant investments made last session in behavioral health services, but we're plugging holes in a sinking ship. We repair one hole and then another appears. A statewide strategic plan for behavioral health formed with provider and consumer engagement is critical. And so we thank you for passing LD 1262 into law last session, directing the department to do exactly that. And we look forward to working with them to meet that change or to that charge. In the meantime, increased funding and regulatory flexibilities for intensive community services like ACT are desperately needed to expand access to the very services and supports that reduce overutilization of hospital EDs. Others have described what ACT is, but I would again add that given the high level of need of the clients served by ACT teams, it's critical that clinical psychiatry be a component of that ACT team model. And I would also add that Maine Behavioral Health Care, our own clients served by ACT teams, have seen a 28% reduction in hospitalization days compared to similar clients not served by our ACT teams. But despite its success, ACT services are woefully underfunded. And we subsidize our 4 ACT teams by almost $1 million annually. And so while this is a significant burden on our budget, we've seen a number of other agencies succumb to the underpayment by eliminating their ACT teams. So in addition to increasing the reimbursement rate to account for the actual cost of providing care, including skyrocketing labor costs so that we can recruit psychiatrists, which thank you to Representative Madigan and this committee for LD 582 last session. Our ACT teams continue to struggle to meet the increased demand for services due to several regulatory barriers that are not included in the current bill. And I would direct you, just in the interest of time, to my written testimony, but that would include allowing ACT teams to bill for more than one contact per day when this benefits the client, changing expectations around ACT psychiatry visits. So currently, ACT clients must see the ACT psychiatric provider 1 time per month in order for providers to bill for the entire month. So if a client doesn't make this contact, despite our attempts by staff to facilitate this contact, all other team contacts can't be billed for that month. And then lastly, appropriately and accurately accounting for travel time to expand into rural areas. I would just close by saying that there's no simple solution to solving the behavioral health crisis, nor will it be solved overnight. But the current system has reached a breaking point, and we need your support and the administration's support to ensure that our residents with behavioral health needs have access to timely and appropriate care. And I would just add that our hospital EDs need to continue to have the capacity to meet the medical needs of our communities. So I would close by saying thank you to this committee for its support for increasing the reimbursement rate for ACT last session. I hope it will be funded this session. And we encourage the committee to also address the regulatory barriers that are included in my written testimony. And I would be happy to answer any questions that you may have.
Has this testimony raised any questions for anybody? I'm not seeing any. You list a number of items for improving ACT team support. Is that in a bill somewhere else, or were you hoping to have us expand this one?
it is not in a bill somewhere, and it would be wonderful if you could expand this bill to include those.
So,
And I'm happy to go through them. I know that I was butting up against the 3 minutes, so I was trying to be quick, but
so not seeing your written testimony, can I ask to make sure that you submit that so that we can have those for the record as we try and process them in the work session?
I did. I'm sorry. I was very late today, but it is submitted and should be in your committee files.
Okay, I haven't hit refresh in the last 2 minutes, so I don't, last few minutes, so I don't know. People are constantly sending things in. So yes, and I assume that you could be available for a work session if we decided we wanted to go down that road.
Yes, I would be happy to.
Thank you. Any other testimony to be offered with respect to LD 1848? I'm not seeing any. I don't see any hands up. So that will conclude the public hearing portion of LD 1848. Are there any questions for the analysts? Representative Zager.
Thank you, Mr. Chair. I guess I just am wondering if we could seek input from the Maine Medical Association. They usually have an opinion on bills of these sorts of matters, and I'm wondering if there's any technical issues that have precluded that for the work session, or unless they're in the attendees.
Okay. Any other requests? I don't see any. So I think that will conclude our work on 1848. That would bring us to consideration of LD 1792. And as I understand it, although the list says otherwise, Representative Berry is here to present this bill. Welcome, Representative Berry. When you're unmuted, we'd love to hear about this bill. There we go.
Wonderful. Thank you very much, Senator Claxton, Representative Meyer, members of the HHS committee. It's great to be with you. My name is Seth Berry, and I proudly represent House District 55, which is Bowdoin-Bodenham, most of Richmond, and beautiful Swan Island on the Kennebec, which has finally frozen over. And it's my pleasure to join you today to present this bill, LD 1792, an act to support employees of the Riverview Psychiatric Center, including the Riverview Psychiatric Center Outpatient Services Team. This bill would provide an immediate increase to wages for all employees of Riverview, including the outpatient services team, by $3 per hour. As you know, since its creation, Riverview has been a very fragile cornerstone of our state's mental health safety net. Only recently, as you also know, has Riverview been recertified and fully staffed. So at long last, we see the potential, and I emphasize potential, for the consent decree to wind down and the dark stain on our past and our present to be at least partially lifted. So as you will hear today, and we'll certainly see in the over 100 items of public testimony submitted largely by those who are most aware of the situation on the ground at Riverview and in outpatient services, employees are enduring punishing, unsafe, exhausting, and often dehumanizing working conditions. They're doing this for the sake of those they serve, not merely for pay, but burnout and turnover is a significant factor and one that we ignore at our peril, especially now as the so-called Great Resignation continues and as inflation is driving workers to seek higher pay. Just to put the pay there in perspective, I want to share from a personal standpoint my son's experience during the summer and fall of 2020 and 2021. My younger son, who was 16 and then 17, worked as a dockhand, a busboy, and a gas pump monkey at a tavern and marina in Bath. He worked full-time, had no particular credentials for the job other than being able-bodied. And for that work, he unskilled labor without a high school diploma. He took home $15 per hour plus tips and averaged well over $22 per hour in total. Many of his friends in school have been working as well in similar paying jobs, again, without high school degrees even required. At Riverview, as I'm told, the starting pay is $15.71 for a mental health worker. Again, my son was bringing home $22 an hour. In addition to that $15.71, apparently there's a temporary $2 stipend. And if you started today at Riverview with a master's degree, you would be earning still less than my son, $20.87 plus a temporary 60-cent stipend. So my son has been earning more for the past 2 years, starting as a 16-year-old, than someone with a master's today at Riverview. Certainly, I hope we can agree that given the importance of their work, the challenges these workers face, and you'll hear more about that in their testimony, it is imperative that we do better. As the great leader Nelson Mandela once said, and I quote, "A nation should not be judged by how it treats its highest citizens, but its lowest ones." And indeed, virtually every great moral leader throughout the millennia has said something similar to that. Riverview has been and still is a prime test of our ability as a state to stand tall as a moral state and a moral society. So with that, I urge the committee to support this bill, these workers and their clients unanimously. And more crucially, I hope you will urge our colleagues on the Appropriations Committee to include this pay raise directly in the coming supplemental budget. These resources we will need are clearly now available, so long as we all make it a priority. Thank you for listening, and I'm happy to try to answer any questions.
Thank you, Representative Barry. There's a question from Representative Craven.
Thank you, Mr. Chair. Thank you, Representative, for bringing the bill forward. My question is about Dorothy Dix and wondering why that facility wasn't included. As you might guess, we've been getting emails from staff at Dorothy Dix, and I'd like your opinion about that.
Thank you, Representative. That's a great question. And, you know, to be very honest, I don't understand the differences between those two services and the populations they serve well enough to have as informed an opinion as you would on that issue. I would absolutely applaud the committee if it chose to take on that additional center and those workers there who I'm sure are deserving of an increase as well. And I think, you know, we all need to be thoughtful about what we prioritize in this coming budget. I think Riverview, with its services to forensic patients, people who have committed murder, people who have committed, you know, very dangerous acts, and who remain potentially dangerous if not given adequate services, are a particular need. But I am very interested in supporting Dorothea Dix and the important work that they do as well. So I trust the committee to do what's best.
Are there any other questions, Representative Barry? I'm not seeing any. So let's go to Jeff McCabe. Welcome.
Good morning. Can folks hear me all right?
We can.
Excellent. I feel like I should always check because that's what the trend is in the morning, typically, I see on these hearings. But Senator Claxton, Representative Meyer, members of the Committee on Health and Human Services, my name is Jeff McCabe. I have the privilege of serving as the Director of Politics and Legislation for Maine Service Employees. We are a labor union representing over 13,000 workers, including workers at both Maine state psychiatric hospitals, Riverview, as well as Dorothea Dix and the folks in the outpatient service team as well. We're here today in strong support of this emergency piece of legislation. And just to start off, there was already a question in regards to including Dorothea Dix as well. And that would be something that we would be supportive of. And a little bit of history, I'm pretty sure that this bill was brought forward by folks at Riverview. So that's why its initial focus on focusing on those workers there. But we do feel that it's important to include Dorothea Dix as well. And I know that you've heard from a number of our members. As you have heard from these frontline workers today, as you have seen in over 100 pieces of written testimony as well, the legislation is necessary because of the ongoing public employment recruitment and retention problem that Maine state government and other employers here in the state of Maine are facing. And this constitutes an emergency. The recruitment and retention problem is particularly acute at Riverview and Dorothea Dix, and the worker classifications such as intensive case managers, the ICMs, and acuity specialists. Let me just share with you some information about these workers. ICMs provide crucial services to Maine and targeted groups of high-risk mental health clients in a local community. And according to the Bureau, the individuals who are ICMs, the most problematic and high-risk mental health patients here in the state of Maine. ICMs are one of the support and integration into our community. Acuity specialists provide emergency response to adults experience moderate to acute psychiatric psychosis. This is clearly difficult and dangerous work, and these workers and all their co-workers are doing in support of Maine's most vulnerable people, yet the state has continually and consistently fallen short when it comes to the respecting and protecting and paying these workers their fair wages. As many of you know, on average, state employees make 15% less than their counterparts in New England, and even after adjusting for regional pay differences, according to the State of Maine market study dated November 20, 2022, this remains the case. I know that I'm limited to 3 minutes today, and I did just want to wrap up. You have my written testimony, but I did have an opportunity this morning in between another meeting and before this hearing started, just to read over the state's testimony. And I think what was missing in the gaps in that testimony was any sort of recognition or reference of the ongoing pandemic and its effects on these workers. There was no information on the vacancy rates that exist at these state hospitals. There's no reference here to efforts associated with hazard pay or the lack of hazard pay. And there's no information here in regards to the retention rate at these facilities. So those are just some things that I would flag and feel that those are very important into the conversation, and would look forward to hearing that conversation possibly at the work session, and also would offer my time for the work session as well as others. And you have a number of written testimony, and I know that some of our members were having a little bit of difficulty getting on the hearing this morning, so I'm not sure if there's more folks in the queue, but you should be hearing from workers directly via email, and hopefully some of those folks will get on and testify today as well. But thank you, and I probably have gone over my 3 minutes.
Thank you, Jeff. There's a question from Representative Meyer.
Thank you, Mr. Chair. Thank you, Jeff, for being here today. I'm curious to know about the use of travel nurses in the two facilities, the extent to which we are using those individuals.
Yeah, thank you, Representative. My understanding is that there are travel nurses being used. I've heard questions come up from Riverview from our members, and I don't have sort of the overall numbers of travel nurses being used, but I think that that is something that I've heard come up in regards to needing to fill capacity. And I know there's, definitely some staffing concerns, and I know that travel nurses have been used. And I don't know if that's information that the department would provide as far as the number of hours, but typically with travel nurses, that service is vital to healthcare, but it comes at great expense. So yeah, I would be curious to look at that. I would also be curious to look at overtime numbers as well, just to see if what that overtime looks like. I know overtime has been a huge issue for corrections during the pandemic, and I can only imagine the same is for the state hospitals as well.
Representative Perry?
Yes, thank you. I do have a question, and I guess this is what, as a union, you could sort of tell. The labor definitions or job descriptions in both hospitals, because they are state employees, I'm assuming are similar. Am I correct?
That should be the case, Representative. Yeah, and I think that sometimes what we see is job classifications may be used at one facility and no longer used at another facility. So I would think for the most part, they would mirror the same. There may be some that are slightly different, but overall they should be the same.
Okay, so one thing we're looking for, and I guess this is the question I'm asking, is that there actually be a pay raise for those job classifications that would be in both facilities, regardless of where the facility is. And because if it's the same in one facility, in terms of being underpaid and the difficulty, it would be the same in the same facility because of the same issues, I'm assuming.
Yeah, Representative, I appreciate you raising that. And I know that you have experience with collective bargaining agreements, and that's a good flag. I actually think that's a much better approach. We have a great deal of difficulty when these things are done regionally. So yeah, I can look at that. We can get you that information for the work session as well.
Thank you for that question. Are there other folks with questions? Mine was about when the last, oh yes, Representative Javner, go ahead.
Thank you, Senator Claxton. Okay, so Mr. McCabe, it just begs the question then, why is this here before our committee today and not in a collective bargaining situation for the employees and everyone to work this out?
Yeah, thank you, Representative, for the question. MSCA did just wrap up a collective, there is a new collective bargaining agreement in place that was done through negotiations, wrapped up at the end of this summer. And, you know, we're here before the legislature because of just the emergency nature. We're very concerned with the lack of staffing. I actually think that both at the state hospitals, as well as corrections, as well as a number of areas, you're going to see me probably next week talk a little bit about this with Child Protective. You know, we're at a crisis. You know, we cannot continue to maintain these vacancies in these key services without the legislature getting involved. We look at this as an opportunity for the legislature to spend necessary resources to actually make sure that positions are filled and that we're staffing these facilities and other facilities around the state at a safe level. We also find it vital that we make investments in this workforce for retention purposes. And that's really why we're here before the legislature. The legislature has the ability to put forward stipends legislatively. I think that's another piece that might have been left out of the state's testimony. It's something that's been done in the past in law enforcement. It's something that's been done in the past in Child Protective, is that the legislature will look at sort of the crisis that exists, make that investment, and then long-term those stipends can be absorbed within the existing collective bargaining agreements. I believe you're going to hear today from another union. We're not the only union that represents these workers at these facilities as well. So I guess that's why we're coming to you. We also are looking at a time when the state is facing, you know, record revenues. There's a surplus. You have an opportunity to make investments in this workforce and to make sure that staffing is at an adequate level.
Thank you. Can I just follow up with one quick?
Please.
Thank you, Senator Claxton. I appreciate that. So therefore then, from my understanding, and any and all other unions that represent these workers, as we continue through this public hearing, if you would like to just express to us as well what you really see the bottom line here, the bottom issue from what I'm hearing from you, Mr. McCabe, is that it's a workforce issue. It's retention and workforce. Is that correct?
I would say it's a retention, a workforce. It's also being competitive. You know, the state needs to be competitive. These are not easy jobs. You know, also, as this pandemic continues, we continue to see increasing numbers of COVID at these facilities amongst staff, amongst patients, and that's extremely alarming. That's going to make it harder and harder to staff these facilities in the future. And
Thank you.
yeah, thank you, Representative. I appreciate the dialogue.
Representative Stover, did you have a question?
Not a question, just a comment that for the work session, if we could have some more data on the staff vacancy and retention rates at both facilities, included Representative Meyer's request for the number of traveling nurses, if any, at both facilities, and an update on the current status of hazard pay, if that's still being used, would also be helpful for me at the work session. Thank you.
Thank you. Any other questions or concerns? So one of mine is that if we're to do a reasonable fiscal note, we'd need to know how many people would be impacted at both facilities, because we've done things that a committee has in the past that has helped drive people from one facility to another or one role to another. And I don't want to create that kind of movement. So if we don't increase to a certain number of folks at Dorothea Dix, matching with those at Riverview, we're going to create an incentive for people to move from Dorothea Dix to Riverview. And I don't think that's a healthy thing. So can you work with the department or other unions to get a sense of how many people would be involved with this $3 across the board change?
Senator, thank you for that question. I would probably reach out to the department. I could also reach out to my counterpart at AFSCME as well, just so that we can work on getting the most accurate sort of head count. I think what we would want to do is look at filled positions, but the overall head count at these facilities as well, just so that we are working on a very accurate estimate for that.
I want to go in with this with a reasonable fiscal note. Representative Stover, is your hand up again or still? Okay. Any other questions of Jeff McCabe? Thank you, sir, for being here.
Thank you.
Next, we'll go to Jim Durgan. When you unmute, we'd like to hear what you have to say.
Thank you, Mr. Chairman. Can you hear me okay?
We can.
Well, thank you and members of the committee. For the record, I'm Jim Durkin here on behalf of AFSCME Council 93 in support of LD 92. Look, well, we're always working to improve the wages of the roughly 2,600 men and women we represent in Maine. We always welcome legislation like this that provides an immediate across-the-board increase to supplement what we're able to achieve at the bargaining table. And while we greatly appreciate this particular effort, and I'm extremely grateful to Representative Berry for filing the legislation, I would be remiss myself if I did not begin by respectfully requesting that the bill be expanded to cover the roughly 200 or so state mental health workers we represent, as opposed to simply the workers at Riverview. Doing so is not only the fair thing to do, but will also be a big help in recruiting and retaining qualified, experienced workers off in the system, which we've already heard is a big problem. Look, needless to say, the jobs of all the state mental health workers, including not just our members at Riverview, but also our crisis workers and our members at Dorothea Dix, are extremely challenging and dangerous, even under so-called normal times. They work in high-stress environments, regularly deal with things like violent physical assaults from the individuals in their care. And when you throw in the stress of working every day throughout this pandemic, including the days before we had a vaccine and adequate PPE, you got a work situation that few of us would want to experience, and I dare say many would have walked away from. But these men and women didn't do that. They continue to report to work faithfully, as they do today. And today and in the coming days and weeks, you'll most assuredly hear from these workers in their own words about what they're enduring, not just over the past few years, but for many years before the start of the pandemic. And that's a good thing, because there is no substitute for hearing directly from the people who do this very difficult job every single day. in closing, I just add that if any member of this committee is interested in meeting directly with a group of these workers for a more in-depth discussion, or perhaps even visiting one of the facilities, we would welcome that, and of course be happy to arrange it at a time that suits your busy schedules. And of course, we will make ourselves available for the work session going forward. I guess, the only thing I would add, I believe it was Representative Chavna that had the question, what is this issue? And in addition to what my colleague, Mr. McCabe, said, I would add that it is also a safety issue. When you're short-staffed, when you're having trouble recruiting and retaining people, and people are burnt out, they're working overtime, that's when bad things happen. And so I think it's really appropriate to view this also as not just a recruitment retention issue, but also a safety issue. And I thank you for your time and consideration, and I'll do my best to answer any questions you may have.
Thank you, Mr. Durgan. Are there any questions of this testimony? I'm not seeing any, so thank you for being here.
Sure, Mr. Chairman, if I could, one more. One member of the committee asked for an update on hazard pay, and I can give an update on that. I'm happy to report that just over the weekend, we reached a settlement on the hazard pay agreement that was stopped by the administration. Just a little bit of background. It was believe back in April that we reached an agreement to provide an additional $3 to $5 per hour, not just for mental health, but for our corrections workers. And the agreement stipulated that it would run through the end of the declaration of the state of emergency, which was, I believe, June 30th, around there. The administration had just abruptly stopped those in December, despite what the agreement said. So we were able to work that out and essentially make those workers whole, again, both in mental health and corrections. So I just wanted to provide that update because I know the question came up.
Okay. Next, we'll go to Christopher Kinraid. Welcome.
Thank you, Senator Claxton, members of the committee. I do not have anything prepared today because I have just returned to work from an injury, but I was asked to speak to you on behalf of the acuity specialist. I'm an acuity specialist at Riverview Psychiatric Center. And I was kind of here if you had questions for the floor staff or to voice our concerns, because the $3 increase is going to increase our retention and the consistency of staff coming in, because we do a very dangerous work here. And it can be difficult to find good staff that have the education and skill sets required for this position when they could go and work, as Senator Berry said, at McDonald's and receive a higher pay.
Let me follow up then and give you the opportunity to speak to some things that you inadvertently put in chat that were not that we're not using. So it becomes part of the permanent record. You spoke to acuity specialists and outpatients were present at both locations. So you're confirming that they're both at Riverview and Dorothea Dix?
The positions are at both facilities, as far as I understand, correct, yes.
Okay.
And job descriptions are the same.
And what you also put in the chat function was mentioned that hazard pay hasn't been in place at Riverview for the past 8 to 12 months. That seems a little different than what I think I just heard.
That was in reference, what Jim had said was we had a contract where it was supposed to be until the end of the pandemic, but then it was stopped on the date that Jim had voiced.
Okay.
And we haven't received it from that point forward.
I just want to make sure that those were part of the public record. So thank you.
Yeah. To touch upon his comment about the safety, though, I've just returned after 5 months out for having my leg broken in 4 places by one of our patients. So if you have any questions regarding that as well.
So are there questions of Mr. Kinrad beyond what he's offered at this point? I'm not, a hand up, Representative Stover.
I just wanted to acknowledge, Mr. Kenray, your injury, and also I hope you're feeling better and that your return to work is good for you.
Thank you very much, ma'am.
Very good. Are there any other comments? Sure, Representative Meyer.
Thank you, Mr. Chair. And thank you, Christopher, for being here today. I echo Representative Stover and hoping that you have a safe return to work. Just a little bit more clarity over this hazard pay issue. When you received it, when it was stopped, and I'm confused over the time frame there.
Okay, I do not off the top of my head know the exact date it was stopped, but at Riverview, all of the floor staff, we received a $5 per hour hazard pay that was supposed to be concurrent for the entirety of the pandemic. It was a few months after the beginning of the year before the governor lifted the pandemic or the standing for it, and they cut that out of our payroll before it was promised to be stopped.
Okay. Any other questions? Thank you, Representative Stover.
Just again, for the work session, I'm still a little confused about hazard pay and when it was paid and to which, was it both unions? So maybe in the work session, we can just have an overview, a very specific overview of the status of hazard pay now and currently. I still feel a little confused, but I'd like to wait till the work session. Thank you.
Okay. Any other suggestions, questions, concerns that should go to our analyst? Representative Zager?
Thank you, Mr. Chair. Just a clarification, Mr. Kenray, thank you. And I'm glad that you're better now, and best of luck for your recovery. Just a clarification, there is, you identified yourself as an acuity specialist at Riverview. There is somebody named William Kinraid who identified himself similarly. Is that who submitted testimony in writing? Is that you, middle name or something? Or
yeah, that's actually my brother. He works at the facility as well.
Okay, fair enough. I just wanted to make sure that I wasn't assuming the wrong thing. Thank you.
Mental health is a family field.
Fair enough. Well, it's an important one. Thank you.
Okay, I don't see anybody else with hand up who wants to testify in support. So now we can go to hear from Brina Bissell, who wants to testify against. Welcome. When you're unmuted, we want to hear your testimony. There we go.
There we go. I think I'm here now. Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I am Brina Bissell, the Director of the Bureau of Human Resources. LD 1792 seeks to immediately increase wages of all employees at the Riverview Psychiatric Center, including outpatient services, by an additional $3 per hour. We certainly understand the sponsor's good intent to affect the compensation of the hardworking employees of Riverview through legislation. However, the Bureau of Human Resources fundamentally opposes increasing pay through legislation and instead recommends the avenues that already exist in statute, civil service rules, and collective bargaining agreements to conduct analytical review and make appropriate determinations with regard to compensation for all employees. Please allow me to highlight these existing processes, and I'll just highlight these. You have more information in my written testimony. First is collective bargaining. The state's Labor Relations Act requires the state and its bargaining agents to bargain collectively in good faith with respect to wages and other subjects. As such, the bargaining table would be a more appropriate forum for addressing the pay increase requested by this bill. In fact, at the bargaining table, this administration has negotiated a number of wage increases totaling over 13%. And they've also negotiated other very generous benefits, including 4 weeks of paid parental leave. So that would be for a mother or a father upon birth or adoption of a child. Next, the recently negotiated classification and compensation study agreed to through collective bargaining is underway. The consultant for the study, Siegel, has made recommendations on classification structure, and those recommendations are being reviewed by the Bureau of Human Resources and agency subject matter experts. The project team reports to the steering committee, which includes members from DAF's, Bureau of Human Resources, the Governor's Office, and the Maine Service Employees Association. Though the project team has not yet met with DHHS on classifications specific to its agency, including many of those at Riverview, such reviews will be taking place in the future. As part of this study, Siegel provided a 2020 wage comparison report of benchmark positions, and some of those benchmark positions at Riverview were found to have minimum pay at or above market, even back in 2020. Others, mostly administrative positions that are found at Riverview, but also all over state government, were found to be below. As already noted, there have been several negotiated wage increases since the 2020 report. Benchmark classifications found at Riverview that, Next, the reclassification process. The state has a longstanding process through the Bureau of Human Resources to evaluate proper classification and determine through a functional job analysis whether the position or classification should be reclassified. This process also determines the correct associated pay for the requisite job. The collective bargaining unit agreements have negotiated language related to reclassification and an appeal process. And lastly, recruitment and retention stipends. 5 MRS Section 7065 compensation plan allows for the approval of recruitment and retention adjustments when the payment of an adjustment would aid the recruitment and retention of an adequate workforce. The statute provides the process and the criteria for such a stipend. It's important to point out with respect to the bill before you that the Department of Health and Human Services has 2 psychiatric hospitals, and you've all noted that already, Riverview and Dorothea Dix. Singling out one entity would impact the parity among the employees. Also important to note is that many of the position classifications at Riverview are not specific to hospitals, but are found across state government in many other departments. For example, accounting and other administrative positions. Following established procedures allows the state as an employer to thoroughly review requests for pay increases in an organized manner consistent with set procedures, ensuring a comprehensive overall view of all related state positions. Increasing pay through legislation contributes to pay inequity across state government. Legislatively increasing pay for one facility but not another, or for employees in classifications of one department or facility but not others, creates an imbalance. Again, while we certainly understand the good intentions of this bill and we respect and support our employees who carry out this important work at Riverview and Dorothea Dix psychiatric centers, we suggest utilizing collective bargaining, the classification and compensation study that's underway, and the already established procedures rather than adjusting pay through this bill. Thank you for this opportunity to testify, and I'm happy to answer any questions.
Thank you for this testimony. Are there any questions of Brina Bissell? I'm not seeing any, but you referenced that your written testimony expands on your reference to established procedures a little bit more fully.
On some of the negotiated increases in benefits, and it expands more on the study that was the 2020 wage study from Siegel.
Thank you. Representative Stover?
Yes, thank you. Ms. Bissell, would you have any additional information about the hazard pay that you could share if you've been listening in? It was
I do. I do, and I'd be happy to share that with you, Representative. Thank you.
Thank you.
In fact, I just signed the agreement that Mr. Durgan spoke about for AFSCME. So we will be making all the AFSCME employees whole. And what happened was, I believe it was April of 2020 or around that time, that the state entered into some agreements for hazard pay, $3 to $5 an hour. And most of the employees at Riverview were receiving the $5 an hour. And it is true that the language of the very first agreements, the initial agreements we did, said till the end of the health emergency. At that time, we all thought that was going to end very quickly. We learned with later agreements to put an actual end date in, or to say they would end within so many days notice. Because what happened was at the end of December of 2020, the funding that we were using for the hazard pay that the federal government had made available was ending. And the health emergency had not ended yet. So we were in curtailment. We had a budget crisis, and we were expending this money, and we had no choice but to end that extra payment in order to keep people in the positions so that we could fund their positions. So that hazard pay did end. And it was only a few agreements that had that language, by the way, not all of them. So we did, for the agreements that had that for AFSCME, we've been in negotiations, and we will be making those employees whole. The payments should be paid in March of this year.
Thank you very much.
Does that then create a disparity between the MSAA folks and the AFSCME people?
The MSEA agreements that had similar ending language had filed grievances on that very same thing, and we've entered into the negotiations on settling those grievances.
Okay. So the answer is sort of yes, if we don't, depending on how things go with the negotiation. Yeah,
we just began those negotiations. We really were addressing one at a time, and so we're on to the MSEA had fewer positions that were impacted than AFSCME did.
Okay. And the classification compensation study, we're not likely to get anything that would be useful to the committee from that study in the next month or two, are we?
I know that we'll be preparing an update to the committee that we need to report out to for March.
Which would be late in our short cycle. Okay. That's what I was just trying to verify whether we wanted to wait for that result or that might be helpful in our deliberations. Thank you for those two pieces of information. I appreciate that. Are there other questions? I don't see any. So thank you for being here and presenting that. So I think, there's a hand up. We can bring in Jean Bilodeau, who was initially listed as, oh, she's not on my list, so we'll defer to her and she can tell us what she wants to testify about. Welcome, Jean. We can hear you now. We can't see you yet.
Hi. I'm trying to get the video to go on, but it's not letting me.
There you go.
Oh, there I am. Okay. Hi. I worked at Riverview and I've worked at outpatient services. I was an acuity specialist at Riverview on the forensic unit, and now I am doing the coordinator position at outpatient services. I do go over there frequently to fill in for overtime. There is a list every single week of needs for mental health workers and nurses. Staffing puts it out quite frequently. It's gotten to the point where I've heard people saying, I've been left alone on a SKU, which is the secure unit, with dangerous, violent people who are, actively psychotic, refusing medications. I've seen blood spilled more there than in a lifetime when I worked there. It's not a pleasant place to be at times, but people try their best to help those who are unfortunately very sick. But it's just getting to the point where there's less and less staff coming in, they're burnt out. They've worked so many hours. I am in favor of, just an increase in the pay to maybe keep some people there. And like it's been said before, there are people, working at Walmart making more than these people who put their lives at risk. And it can be quite serious. A lot of people have been hurt, hospitalized, because of the safety levels. When you have acuity on a unit and there's 3 people on one and you've only got 4 staff, there's no one there to watch the floor. Somebody is just going to have to go around doing checks. Nobody gets a break. They work 12 hours a day. No break sometimes because there's no one to relieve you. I came here to get a break from there, but I still go in and help because I know what it's like for the people who are working there. And, as somebody asked me about this, the pandemic, it's got people gearing up all the time, like on one of the upper units, it is now the COVID unit, and people have to wear full gear, the face mask, everything, the goggles, the gowns, the gloves. And when you're doing that for 12 hours a day, that's quite, it's hard. And as far as the hazard pay thing goes, now, see, we're not included in that because we're outpatient services. Even though we were seeing patients, it didn't matter because we weren't in those 4 walls. But that has really nothing to do with what we're proposing for this. It's the $3 an hour. The risks that people face every day when they go to work, it's not like your typical job. When you come in, you don't expect to get assaulted, spit at, called names, threatened. But that's a daily thing sometimes there.
Okay. Thank you for sharing that perspective, your perspective. Are there questions of Jean Bildo? I'm not seeing any. Thank you for being here and stay as safe as you can. So I think that means we've heard from everybody who wants to testify for, against, and neither for nor against on LD 1792. So that'll conclude the public hearing portion of this consideration of this bill. So then I would ask if anybody has questions of our analysts. And before I do that, we'll give Senator Baldacci a chance to introduce himself and say hello.
Chairman, my name is Joe Baldacci. I represent the city of Bangor and the town of Herman and Senate District 9. Just to follow up though, Mr. Chairman, on what you had asked, I would note that I would probably ask the staff for amendments to see what the costs would be of extending this pay raise to workers at the Dorothea Dix Psychiatric Center. I've been a couple of dozen workers there have contacted me in support of this bill, but they would like to see that their facility be treated equally. These are the 2, Riverview and Dorothea Dix are the 2 psychiatric hospitals in the state. They both have very challenging jobs. People deserve more. So if we could get information, maybe I would like to work on an amendment to include the Dorothea Dix facility as part of this. Thank you, Mr. Chairman.
And when that difference was raised earlier, that was the gist of the question was asked. What's the impact to including Dorothea Dix in the fiscal note? So yes.
Thank you.
So Sam, do you feel like you have the information you need, Sam, to Sam's? Yep. Okay. Yes, Representative Zager.
Thank you so much, Mr. Chair. And I just wanted to ask Sam if you could also clarify in the work session, Ms. Bissell in her testimony, it says that there's an upcoming 4% wage increase to be effective this coming July 1. And my question is, given the language of this bill that we're considering, would that be a complementary, or would that run concurrently? In other words, would a 3% be irrelevant if they're already going to 4%? I'm not sure of the mechanics of the language. Thank you very much.
Yes, Representative Meyer.
Thank you, Mr. Chair. I just wanted to remind the committee that there is a plethora of testimony that has been submitted in the system, well over 100 pieces, the majority of which are current and former workers at both at both hospitals. And as I know we all do, I would ask that you make the time to read through that testimony. It is compelling. These folks live in our districts and we represent them.
And they're doing crucial work, as are many other folks right now. Okay, so I think that'll conclude the public hearing portion of the consideration of LD 1792. As I understand the schedule, and feel free to correct me, we'll reconvene at 2 o'clock. Does that sound right, Sam?
Yes, maybe we can connect offline about scheduling with the leads and chairs.
We can do that afterwards, right? Okay, very good. See everybody at 2 o'clock. Thank you all. Hello, Senator Moore.
Hello there. Made
Good
it
to see you
safely.
safely. Yes. Looks like you have your Storm Center sweater on.
I do. I do. Just in case, I didn't know if I was going to have to get out, put my grippers on my boots and do something with the vehicle to get it going, but it was fine.
The winter equivalent of the umbrella.
That's true. You're right. Absolutely. That and a bag of kitty litter. Do we actually have a report that we're going to be reviewing, or is it the dashboard we're going to be talking about?
I think this is an educational session for the committee as we pay attention to the overdose issue
Okay, thank you.
in the first instance and learning about psilocybin in the second.
Okay, right. Perfect.
Actually, we thought you were going to give the report. Surprise.
I would have been practicing it all the way on Route 9, right?
How was Route 9, by the way?
It wasn't too bad. And I really, the couple spots that were bad were there by that Mopang. That was probably the worst section, you know, because it's so shaded in there. None of the truck lanes were plowed or sanded. So everybody was driving in the main lanes, including the trucks.
Right.
But once
So
I got
slow going.
Yeah, but once I got to Brewer, it was fine all the way from there.
I figured that. Yeah. It's Route 9. It's always the fun part.
Oh, it was fun, that's for sure.
So it being just slightly after 2:00, I think we can resume our committee meeting. In this instance, it's an educational session for us. We want to hear from Dr. Sorg and Roy McKinney about their perspective on our current struggles with substance use disorder. And we appreciate they're making some time in their afternoons to help the committee be a little bit better informed. We can quickly introduce ourselves, and I'll start with Representative Lemelin.
Good afternoon, everyone. My name is Michael Lemelin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good afternoon. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Representative Perry.
Apologize for the phone. I am Representative Van Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Calais, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Craven.
Thank you, Mr. Chair. Good afternoon. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Griffin.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadusket.
Senator Moore.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Thank you, Mr. Chair. Good afternoon. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott, where I live, and parts of Kittery and South Berwick.
Thank you. And I'm Ned Claxton. I represent Senate District 20 and serve the people of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. The people who keep the committee organized and running right are also here. And so I'll have Sam introduce himself.
Sam Seneft. I'm a legislative analyst with the Office of Policy and Legal Analysis.
And Anna?
Hi, I'm Anna Broom. I'm also a legislative analyst with the Office of Policy and Legal Analysis.
And our clerk extraordinaire, Karen?
I'm Karen Thomas. I'm the clerk of the Health and Human Services Committee. Should you need any assistance, please email me at hhs@legislature.maine.gov. Thanks.
So thank you all for being here. And for those of you who joined us, Marcella Sorg is going to start, I think. I will defer to you too, but you have some information that might help us understand the nature of our current struggles. Welcome.
Good afternoon, Senator Claxton, Representative Meyer. I'm Marcella Sorg. I'm a research professor at the University of Maine, working in the Margaret Chase Smith Policy Center. And for many years, I think it's approaching 20 now, we've been working on tabulating statistics having to do with drug-related deaths, and we've expanded to other metrics. And I'll be sharing some of those with you this afternoon. I do have a PowerPoint. I can put that up at any time that you're ready. Okay, I see nods. Okay, please feel free to interrupt me with any questions that you have. I'm happy to stop. And let me share my screen. I don't know why it started there, but
Usually we include in the introduction a little mention of technical difficulties, some which are so predictable they're almost planned, and others which we stumble across.
okay. Well, I'm having one now.
That's
But I don't know. I'm almost back to the beginning. For some reason, it started me out at the end of my presentation. So that's what's going on. Okay, I'm assuming you can see this.
We can.
Okay. So I'm going to talk today about what the overdose data are showing, in particular, why this is happening, in my opinion, and what we're doing about it. My team is working pretty closely with the Office of Attorney General, the Office of Behavioral Health, and the Attorney General in pulling these data together. I think you've heard from Gordon and other people, we have been experiencing an increase in the drug deaths. They've gone up 23% just in the last year, and that's an estimate based on what we think 2021 is going to be. We have some delays due to COVID and our national lab not returning our toxicology results to us until about 10 weeks after the death. So our estimates for 2021 are estimates. This is really a fentanyl epidemic, and the proportion of the deaths that are due to fentanyl has been increasing. It increased 10% just this last year, based on the estimated number that we think we're going to have. So it's now most of the deaths. And I want to point out that these numbers are based on all of our overdoses. They do include suicides and undetermined deaths, which are a very small part of it, about 10%. And there are reasons for including them. I will be specific about which statistics are for accidents only a little bit later in the presentation. But for now, 77% are due to fentanyl. As you know, probably it is very much more potent than oxycodone, and even up to 100 times more potent than heroin. And one characteristic is very important. It's fast acting. And we'll talk about that in a minute. Also, more recently, there's a lot of contamination of fentanyl within other kinds of substances, particularly stimulants of methamphetamine and cocaine. Our data reflects the national trends, and they are everywhere being driven by fentanyl lethality. That problem began really 6 or 7 years ago, and the growth since then has been nearly exponential. And as I mentioned, more recently mixed with cocaine and methamphetamine. Our numbers mirror the national trends. That's the important thing. Here you see Maine's numbers, and you can, the red line is all the drug deaths and the blue line is fentanyl deaths. And you can see it follows right along. With a peak in 2017, it then dipped in 2018 and rose again in 2019. This change from 17 to 18 and going up since 19 is a national trend. And here you can see it. These are all, not just fentanyl, but all drug deaths. And you can see that peak again and the rise in 2019. It's a very widely experienced. Here's the increase. This is the percent increase from year to year. And at the beginning, hardly any, 2013, but then immediately it just started ramping way up until we got to the 77% for this year. Here is a national graph, and nationally they call the fentanyl synthetic opioid other than methadone. And this is because they've had a very specific way of coding things at the federal CDC and haven't really been able to keep to know about non-pharmaceutical fentanyl as early as Maine knew about it. I shouldn't say know about it. They knew about it, but their categories did not allow for a non-pharmaceutical version of fentanyl right away. And so they have had to deal with it with different language. But here's the fentanyl. It started in 2013 and then went straight up. It's a synthetic opioid made in China and shipped to drug cartels in Mexico, and it's distributed to us from there. It's a lot easier to grow than heroin. You don't have to ship as much product, and the user doesn't need as much product to get the same opioid effect. I have been saying pretty broadly, and I'll say it again here, I don't think that overdose deaths are a very good outcome measure of the success or failure of state SUD programs. People tend to focus on it. I would suggest a broader view. They are a biased sample. Lethal drugs are overrepresented, and there are some other issues that I'll get into later. Fentanyl supply is rising and falling due to international drug trafficking, not Maine's policies. So it's a very difficult thing to connect the dots with the overdose deaths when 77% of them are due to fentanyl. The toxicology reports show the mixing that I mentioned, and almost half have either cocaine or methamphetamine. Some of them have both. 16% have pharmaceutical opioids. However, most of them are not prescribed to the individual who died. A new drug on the market or on the scene is xylazine, which is a sedative, and it's present as a contaminant in about 10% of the fentanyl now. Here's a graph of those combinations, and you can see they ramped up first for heroin, which is the blue line, and then next was cocaine, and then third was meth, and meth has now overtaken the others. I think Director McKinney will probably talk about that. The drug supply is spiked with fentanyl, these drugs, cocaine and meth, for example, and users may not know that fentanyl is going to be in it. These fentanyl overdoses are different. They are real in the moment events due to lethality. Because fentanyl is more toxic in smaller amounts, it's easy for the user to misjudge how much they're giving themselves. It acts in seconds, and lots of cases that we find die before they even remove the needle. Fentanyl also has something called the wooden chest syndrome. It's unique with fentanyl. It paralyzes the larynx in that area, and it can prevent resuscitation unless you insert an airway. And I mentioned that users are often unaware that it's there. Another problem is that users are using in isolation, and they are discovered, and the rescue attempts are too late often. Especially with fentanyl, you need an immediate response. And then, of course, naloxone may not be available, and the pandemic has made everything worse. Some comments that Dr. Armstrong, who's on our team, has been, she's been interviewing the distributors of naloxone and talking to them about the impact of the pandemic on the overdoses. And here are some of the quotes from her work. They say that all the safety nets seem to be gone, that the stress tolerance is lower among users. The treatment force, of course, is reduced, and marginalized populations don't have access to the phones and computers necessary to take advantage of telehealth. Isolation means that it's a reduced opportunity for bystanders to save lives. The people are taking more risky substances because of the interruptions to the drug supply, and as I mentioned, may not be aware of contamination with fentanyl. Also, and I don't know whether Director McKinney is going to talk about this, but the public safety workforce is reduced right now. How do you prevent these overdoses? Obviously, we want to keep people alive until they can get into treatment. Naloxone is one of the ways we can do that. And by the way, the research does not indicate that it increases drug use because people think the risk is lower. There's an increasing supply of naloxone in the community. This is necessary for keeping people alive. And we have to be distributing the naloxone to those who will be the bystanders, not to the drug user themselves necessarily. So I believe you've had other statistics just in the period January through November. We distributed about 77,000 doses. They come in kits of 2 in the intranasal form, and that's about 2.9 million. Getting people into treatment, we've increased that with the options program, which in the period up until October referred 263 to treatment, and they distributed almost 1,000 doses of naloxone. What about other drugs? And I just want to make the point that most of the deaths are induced by opioids, either alone or combination. with other drugs. The average is 3 that is listed on the death certificate as the cause. It's not one smoking gun. The medical examiner procedure in identifying causes of death is that if you've got a really toxic amount of fentanyl, say, if you have another drug on board in the toxicology that is also an opioid, even though, that by itself might not have caused the death, the other opioids are still central nervous system depressants. And so the medical examiner will list those additional central nervous system depressants because they act together with the same kinds of opioid effects. They will also note any other drugs that act synergistically with opioids, for example, benzodiazepines or tranquilizers, which utilize the same receptors in the brain. Those get mentioned if the toxicology report includes them. So the toxicology report isn't just one smoking gun, and it is a very complex picture if you're looking at the causes of death. Among the accidental overdoses only, January through June, 100% had one or more opioids listed as a cause of death. And among those, 88% of them included fentanyl. So it really is a fentanyl storm here. We do a new monthly overdose report. Maybe some of you have seen it. It's listed, it's posted as soon as we have it done on maindrugdata.org. And that is allowing us to report on the non-fatal as well as the fatal overdoses. We've discovered that the deaths represent 7% of the reported overdoses in that period. So 93% of people are surviving. And here are the numbers for that period. The shocking thing is that there are over 8,000 reported non-fatal overdoses. And keep in mind that even though this includes a lot of community reported overdoses, we are sure that it is not getting them all because these are not reported frequently. Here's how we did that calculation. This table is the deduplicated categories. This is not their activity, their full activity. For example, law enforcement was involved in a lot more than 12, but they were involved in only 12 that had no EMS present. So the emergency room is seeing the lion's share, 46%. Then we have the EMS, the folks that refused transport, that's another quarter, 25% of them. 22% are reported by community reversals, and 7% are fatal. This is an estimate of the proportionality. We believe that the 7% is actually a lower percent if we knew about all of the reversals that were unreported. Also, we have a new overdose review panel that was established with LD 1718. There are 15 appointed panelists on this review panel. University of Maine is staffing it, and we're examining individual histories and making recommendations. It includes both fatal and non-fatal. Almost all the states have these, but we think we're the only one that where the law allows us to look at non-fatal cases. And right now we're focusing first on people who were recently discharged from jail or prison and who died of overdose. And we're using medical examiner files as the primary data set and then expanding from there. I want to mention that police officers are administering Narcan. In 2021, the Office of Attorney General distributed 5,384 doses to law enforcement agencies. And the officers participated in saving over 300 overdose victims this past year. Also this past year, just through October, law enforcement was involved and reported to ODMAP, the online overdose reporting system, over 800 non-fatal overdoses. Now, the options liaisons, those are not reported in ODMAP, but I'm mentioning also that they participated in 386 co-responses with the options liaisons. They also were involved in 99 fatal overdoses in that period that they reported into ODMAP. They respond to almost all of the fatal overdoses. And the total January through October without EMS there was 17%, and with EMS there was 398. So they are really doing the lion's share of the death investigation right now, not medical examiners. The medical examiners usually see these people at the funeral home. A minority of them are brought in for autopsy. We used to do autopsy on 100%, but we can't possibly do that with only 2 pathologists on staff and all these overdoses. The complexity of naloxone administration is important for people to understand. Looking just at the cases with EMS presence, which is most of them, 49% of them, these are just the ones who end up as a medical examiner case, half of them were already deceased when EMS arrived. We do know that 36% had naloxone administered, and that's up from 33% in 2020. 11% had naloxone administered by a bystander, and that's up from 4% previous year. And usually the naloxone is given also by EMS and often by police as well, and sometimes all 3. And I want to point out that the ODMAP reporting system only includes space for 1. The officer filling that out can only pick 1 as to who administered naloxone, but it's much more complex than that. What we don't know. We do not know at this point the precise prevalence of substance use disorder in Maine. The best evidence is from the National Survey on Drug Use and Health. 8.6 is the estimate for 2019. We don't yet have the estimate for 2020 for Maine. And that would be about 116,000 people in the state of Maine. I think that we will soon have more data from treatment admissions. I'm going to talk a little bit about that momentarily. What data do we have about what drugs are being used among the non-fatal overdoses, or more generally by people who use drugs? And my answer is not much. We do not know what drugs are being used among non-fatal overdoses. And we can assume furthermore that the deaths are not a good representative sample of that drug use, because the drug deaths by definition include more lethal drugs and more IV drug use. So this is another reason that the drug death statistics are not a valid measure for evaluating SUD policy effectiveness. This is some treatment data from Maine. These are the Medicaid claims, and this is 2000, oh, I don't have it on here, but it's 2019. And this is who's getting treatment in the state of Maine in 2019. You can see there were about 22,000 people that made a claim for services. The lion's share is opioids, and alcohol is 12 to 13%. The rest of them don't even really make it onto the drawing board here, although cocaine's almost 2%. I don't think this is representative of what people are taking. This is an underrepresentation of the variety of things that people are taking. And but it's all we have right now for the treatment data. As soon as the APRIS system is up and running, we'll have a much better idea, and we'll also know what their secondary problem and tertiary problem is. So I think that we'll be in better shape for looking at treatment after that. And here is the first 2 quarters, and it includes, as I mentioned, all manners of death. 88% opioids, 77% fentanyl. We've already been through that. A quarter of them are methamphetamine, a quarter are alcohol, a quarter are cocaine, and a quarter are pharmaceutical opioids. And you can see this does not add up to 100% because these categories overlap. 14% benzodiazepines. And you may want to know, what about the other pharmaceuticals? Well, they do get listed sometimes. The average on a death certificate is 3 drugs listed. We have frequently found antidepressants, for example, muscle relaxants, those sorts of drugs. Occasionally, we get something like Tylenol, which causes liver problems. But most of the time, it's an opioid problem. By the way, the pharmaceutical opioids that are listed here, most of them are not prescribed to the individual who died. They're trafficked on the street. So in summary, and these are the reasons in my opinion, for the increasing deaths. Fentanyl, it is toxic, very fast acting. It creates something called the wooden chest syndrome, which prevents you from resuscitating them unless you are able to put an airway in and force air in there. Fentanyl is hidden in the supply, and it is extremely available. The isolation, which has been made worse by the pandemic, people are using alone, but with fentanyl, you need instant response with naloxone. And we still have a problem of reduced stigma, the need for reduced stigma and more naloxone availability. If there were not as much stigma, people wouldn't be using alone as often. International drug trafficking, which is resistant to Maine policies. And of course, workforce shortages, which are the big elephant in the room, reducing Maine's treatment capacity and slowing up our attempts to increase that capacity. The news isn't all bad. We have a pretty good record right now for naloxone distribution and emergency response, and we're saving lives 93% of the time. This is not to minimize the other 7%, but it is news that we didn't have before, and it gives us a broader picture of what's going on. And, I'll stop and ask if you have any questions.
Thank you, Dr. Sorg. I learned a lot when you went through some of those slides at the presentation for the opioid seminar. It's a good chance to see him again and learn yet some more. Are there any questions of Dr. Sorg? So I'll just ask that, assuming that there's a significant underreporting of overdoses, and that a lot of that some of the ones that are treated by support in whatever form and not reported, the 7% is probably the worst case scenario, and we're doing better than that. But that still leaves 7% of way too many.
Yes, that's
Okay.
right. I can't imagine what it would be if we hadn't distributed all that naloxone.
Mhm.
I know that we have heard anecdotally from the syringe exchange folks that they think that 3/4 of the overdoses that occur don't ever call 911. 3/4. And so I don't know whether that number's right, but
Mhm.
I am just using it to indicate to you that I think it's a pretty high number.
And I appreciate that you also emphasize that we're looking at the drugs that are most potent and their impact, and this doesn't really accurately reflect the common usage pattern or more common usage pattern. Thank you for reinforcing that.
Yep.
Senator Moore, you had a question?
Yes, I do. Thank you, Senator Claxton. And thank you, Dr. Sorg. I really appreciate all the statistical information. I guess one of the things in my mind, I had understood that fentanyl is really bad. And we had a couple of people that lost their lives in Washington County. It was mixed with their pot that they thought they were smoking. But I guess when I'm talking about treatments, we've always talked about MAT for, the type of treatments, and it was always about opiates. Do they also work for fentanyl when they have a problem with fentanyl?
Yes, they do. Obviously, the strength of your addiction is the key here, and there's a lot of individual variation. But yes, definitely.
Are there other questions from the committee? I'm not seeing any. So again, thank you for taking time out of your day, and thank you for decades of work in this arena. And I'm glad you have some new toys and some more resources.
Thank you. And it's nice to see some of you again, Anne. So,
Before we go to Director McKinney, can I give Senator Baldacci a chance to introduce himself?
Afternoon, I'm Joe Baldacci. I represent the city of Bangor and the town of Herman, Senate District 9. Thank you, Mr. Chairman.
And Representative Madigan has joined us since we started.
Hi, I'm Representative Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Thank you. So with that, we can segue to Director McKinney. Thank you, sir, for being here. Sounds like you have your hands full.
Thank you, Senator Claxton. And members of the committee, my name is Roy McKinney, Director of Main Drug Enforcement. And yes, the men and women that are assigned to Main Drug by local departments, sheriff's departments, do have their hands full. I'm going to give you a presentation here. It is a Zoom one, and I'll move along quickly, but I think it's helpful to have some visual as we go through this. And so if I might start, and if I can find it on this screen.
There we go.
Yeah. Is that full screen? Okay.
It is.
Thank you. Yeah. Talk about your technical difficulties. This is not it.
Looked like the title page was right.
The title page is right, but it's a Word, Adobe, which isn't what I want.
Mm-hmm.
So,
Well, feel free to make as many technical hiccups as you'd like, because all of us are, have a chance to contribute our experience in that
Yeah.
regard.
yeah, I tested this out earlier, but once you know, the test always goes through with flying colors, but this is just, it's just not showing up on what I can select from on the screen share. But
Director, do you want to take a few minute break and see if you can pull it back up?
well, yeah, I just pulled it up in the background as a PowerPoint, but it's just not showing up on the.
Why don't we take a 5-minute break? 2:45. Sometimes it's easier to have things work well when we're not all looking at you. So we'll kill our videos and be back at 2:45.
Thank you, Senator.
You all set now, Director McKinney?
Yes, Senator, thank you very much for your indulgence in getting this going.
Well, all of us have lives other than Zoom presentations. So, all right. So, given that the right presentation is up and it's 2:45, why don't we get started again? And,
Okay.
Welcome to proceed.
Okay, thank you, Senator. What I plan to do today is provide you with an overview of the agency, its structure, its mission, and provide some data on what the men and women who are assigned to MDEA, the types of drugs that they're encountering, what we have seized, and for 2021, I must say that the quantity of drugs seized, we have never seen this amount previous. So if you can see the title page, I'll go to the next view, which does provide that Maine Drug is a bureau within the Department of Public Safety and is statutorily charged with addressing the threat to the health and safety of Maine residents resulting from the distribution of and manufacture of drugs into, out of, and within the state. It is a task force concept that the agency was created by the Intergovernmental Drug Enforcement Act of 1987, which the legislature reaffirmed in 1992 as the Maine Drug Enforcement Act. The Public Safety Commissioner is charged with establishing and operating within the agency such regional investigative task forces as the commissioner determines are required for effective drug law enforcement throughout the state. As I mentioned, it's a task force concept, so the investigative component of each is comprised of law enforcement officers drawn from municipal, county, tribal, and state law enforcement agencies, all with statewide authority. The agency reimburses the assigning department the salary and benefits of 49 officers in total from 35 law enforcement agencies, so that we have 49 positions. 43 of those are funded through the general fund and 6 are through a federal grant from the Bureau of Justice Assistance. That central approach is augmented with additional officers, 5 officers to be exact, that are assigned full-time by the local department or sheriff's office with no reimbursement for that officer's salary. We also have 3 federal office agents or officers in our Aroostook and Down East district task forces. Those task force groups share an international border. 2 agents are from the U.S. Border Patrol, and a third is from Homeland Security Investigations. In addition, the U.S. Bureau of Indian Affairs has assigned a special agent with a focus on serving Maine tribes. That officer is embedded with our task force group that is based in Herman. And finally, the U.S. Drug Enforcement Administration is a posted duty located within in the Northern District of Maine, housed within a MDEA task force officer. And they have 2 special agents and 1 task force officer that work daily with our agents. We also work collaboratively with the FBI's Safe Streets Task Force, the USDEA's Portland, Maine Resident Office, and the New England High Intensity Drug Trafficking Area Initiative, the Southern Maine Task Force, that is led by DEA. And we assign officers or agents on a case-by-case basis for joint operations. The agency works closely with the Maine Attorney General's Office in the development and prosecution of targeted drug cases in 9 of Maine's 16 counties, with the local district attorney prosecuting our cases in those remaining counties. You can see from this slide that where we fit in the effort of the Maine opioid response in the strengthening of law enforcement and through a collaborative approach. Our organizational structure, we have 2 divisions within the state. Each division is made up of 4 task force groups. Those task force groups are aligned with the prosecutorial districts of Maine. So as an example, Division 2 is led by a lieutenant, and that officer oversees the operations of 4 task force groups, which essentially is from Augusta north, and then south is the Division 1 commander with 4 task force groups. The agents are assigned equally between both divisions. As a structure, we have an evidence manager. We're taking in approximately 4,000 plus items or exhibits for court every year. So we need to assign an officer full-time to manage those exhibits in their custody until they are lawfully disposed of. We also enjoy 6 National Guard Bureau counter drug program analysts that are assigned to us equally across those divisions. Our mission is to reduce the distribution, availability, and use of illicit drugs, employing a collaborative statewide enforcement effort with the goal of undermining the ability of drug suppliers to meet, expand, and profit from drug demand. And while that is where it supports the state's drug prevention efforts in regards to the initiation to drug use, and contributes to treatment efforts by eroding the ability to sustain use, all through that multi-jurisdictional task force approach that I mentioned. Our strategy is to address the upper and mid-level drug dealers that operate below the interests of the federal law enforcement authorities, who focus on international, interstate, and substantial violators. And then the other end of the spectrum being street level efforts that focus on small dealers and those caught in possession. That is our niche, if you will, is taking officers and giving them the sole focus to dismantle and disrupt drug trafficking organizations or groups. And our focus is on those that are distributing heroin, fentanyl, and other opioid drugs, cocaine, and methamphetamine. They are by far the drug threats faced by Maine, in New England, and I would dare say the nation as a whole. We do have challenges in running a task force operation or concept, if you will. A task force approach yields accomplishments while also having distinct challenges. Personnel are constantly rotating in and out of the task force groups, creating training challenges and impacting abilities to further long-term and more complex investigations. Advances in technology and adaptations by drug trafficking groups present yet another set of distinct challenges. At the same time, equipment necessary to fulfill our mission must be acquired and staff trained. The model requires that officers be staffed, and these from local agencies. These agencies have been experiencing challenges in their hiring process. Agencies are competing for qualified candidates, which has drastically impacted MDEA staffing. This challenge has and will continue to affect agents' assignments to MDEA. Over the past year, assigned agents have been temporarily called back to departments to fill minimum staffing positions. In some instances, the agent positions have been left unfilled due to vacancies being unable or agencies being unable to assign officers due to staffing shortages. I would say that We were at 14. We were down 14 out of that 49. Right now, we're at 12, and within the next month, we'll be down only 10. But it does have an impact, unlike other investigations where a detective can be assigned a theft case or burglary and work that case by themselves. The drug investigations require a minimum of 2 and sometimes the whole staff in order to conduct an operation safely. Challenges include that posed by members of out-of-state drug trafficking organizations establishing themselves in Maine's community. They join forces with Maine drug users and those that deal to sell heroin, fentanyl, cocaine, and methamphetamine at significant profit margins over what is seen in Southern New England or the New York markets. Our investigations begin with information, and we receive information through various modes, these drug complaints, if you will, through an anonymous tip 411, as well as our website and an 800 toll-free number. We also assist local departments, and we track these metrics. As you can see, the assists have been going up exponentially over the last 3 years. And we're delving into trying to better track what is driving that. But I will say that we do a lot of field or presumptive testing of seized substances. In order for a department oftentimes these departments don't have the necessary equipment in order to do this safely, so they turn to us to provide them with that assistance, so that they then can bring a complete report and investigation to the prosecutor. The other is Dr. Sorg spoke of drug overdose deaths. The Attorney General's protocol requires that any department that responds to an overdose death has to notify the MDEA supervisor for that area. And the premise behind that is that we are looking for actionable information as to who the supply of the drug was that may have been involved and caused that death. And it's important that that information be received in a timely manner. So oftentimes the supervisor is going to receive that call when that overdose death is discovered. And then if there is an opportunity to work that actionable information, we'll work it with that local department in order to identify who that source is. And you can see from this slide, the last 3 years of the just looking at heroin and fentanyl and meth as the number of cases that we've opened. There's always a lag from the time that we open a case until there is an arrest, and that is a result of case can take a month or several months in order to there to be a sufficient evidence to do an enforcement action, if you will. And as mentioned earlier, heroin and fentanyl pose the most significant threats to Maine. As Dr. Sorg said, it's readily available and at a low price. Heroin use has remained constant. Most reports of heroin seizures and heroin found at the scene of overdoses have also involved heroin. But fentanyl has continued to be the primary driver of the ongoing opioid crisis. And the increased presence of fentanyl in cocaine, in methamphetamine, and other drugs has caused an increase in safety concern for agents conducting presumptive field tests of these substances and their handling of it. We've had to purchase specialized equipment in order to do that safely. This chart shows the amount of drugs that were seized between 2019, the year before the pandemic, and then in 2021, which we just concluded. And as you can see, heroin has decreased. And I must give you the disclaimer here that this is the drug is or the substance is identified based upon the presumptive testing done by the investigating agent. So when it does go to the lab, more likely than not, it will test that, but the lab may find other substances of a smaller quantity within that main substance. But you can see fentanyl between 2019 and 2021 went up 2.5 times. While the same we're seeing with methamphetamine, which we're seeing that I'm sure the committee has heard the issues with methamphetamine labs. Maine did have an issue with that. Last year, we had 2 active labs. What we're seeing now is crystal methamphetamine that is being mass produced in Mexico, smuggled across the border, and is making its way into the greater New England. And at the same time, we're seeing the cocaine and cocaine base. Those amounts just, the stimulant market is just exploded, if you will. And then we do see pharmaceutical dosage units, but I believe last year we may have had only 1 or 2 investigations where the primary drug involved was oxycodone or hydrocodone of that nature. Quite often when officers execute a search warrant, they're going to find those drugs as well as methamphetamine, fentanyl, and cocaine at the crime scene. Last year, this gives a representative sample, or not a representative sampling, but a breakdown of the arrests that were done. You can see fentanyl and other opioids was 100 out of 264 arrests. So that coupled with heroin represents 54% of all drug arrests by the Maine Drug Enforcement, while cocaine is still present there at 30%, and methamphetamine at 16%. And I just put these slides here just to kind of give an idea of the type of work, the response that's being done in various parts of the states by these task force groups. In Presque Isle, 4 pounds of crystal methamphetamine were seized. In Skowhegan, an investigation led to a vehicle stop and a seizure of a residence where we seized nearly 2 pounds of fentanyl and 2 firearms. And then lastly, this case highlights the joint work of task force groups by being under one umbrella that works seamlessly. Ellsworth started a identified case involving methamphetamine, fentanyl, and crack. And that's often what you see, like you see with Dr. Zorg. Unfortunately, in these victims, we're seeing multiple drugs. The drug traffickers are dealing in multiple drugs. They're not dealing necessarily just in one particular drug alone. But this particular case led to our Penobscot-based or Penobscot County-based group to infiltrate a Detroit, Michigan-based trafficking group. And as a result of that, 4 pounds of fentanyl, 3/4 pound of methamphetamine, 3 ounces of crack cocaine, and firearms were seized as a result of that joint operation of these 2 groups. And that concludes what I have for the committee.
Thank you, Director. So are there any questions from the committee at this point based on that presentation? Representative Craven.
Thank you, Mr. Chair. I was just wondering how you know to stop vehicles. For example, it seems like it's such an arbitrary thing to do unless you're working with agents from other states.
Yes, thank you, Representative. That is part, unlike interdiction effort, which is normally the realm of patrol, uniform patrol, in doing traffic enforcement in stopping a vehicle and that leading to evidence to conduct a search of that vehicle. The operations that we do are the result of an investigation where we're learning information that an individual will be headed out of state in order to obtain particular drugs. And in this, one of those last cases was Skowhegan. That is exactly how that case developed. Was the investigators developed that information. The person would be making a trip out of state to bring back, I think that case it was fentanyl. So the investigators set up surveillance and then employed the Maine State Police, who actually conducted the stop in uniform in a marked car. Every one of our enforcement operations, we have uniformed officers and a marked car there, whether it be a vehicle stop or whether it be execution of a search warrant, as our officers all work in plain clothes. And so these can be highly dangerous situations in doing a search warrant. So that's why we have uniformed personnel always present at that. So I hope that, I trust that answered your question.
Yes, thank you.
You're welcome.
Senator Baldacci?
I just wanted to thank Director McKinney, who has served many years for the Bangor Police Department, but also particularly for the bust and the infiltration work done by his agents on that Herman to Ellsworth drug bust. It's pretty serious, when people are coming in from other states to sell hard drugs and to commit other crimes. So I just want to thank Director McKinney. I know that you're short-staffed a lot. What are your numbers? Because obviously we're hearing this from a number of different places as well, but how many agents would you like to have versus how many agents do you currently have full-time?
Thank you, Senator, and I'll be sure to pass that on to those two task force groups, your recognition for their fine work. I tell this to the supervisors and the commanders that the drug enforcement work by task force groups is it's a team effort. It takes a group of officers working together in concert in order to have successful and safe operations. And with that said, that's been a big issue in the last year. And I've been at this job for a while now, and I've never seen it this way, where typically an officer is going to go back next week. We have an officer that very following week from that department, but departments are short-staffed, and the backbone of law enforcement is the patrol division, is your uniform. They have to be there to respond to emergencies. I mean, with that said, we're working diligently with those departments as the academy pushes officers through and they're able to hire to get those 10 open positions back as soon as we can. The other part that I didn't really touch on is COVID-19 and the pandemic and the operations of in conducting these types of operations. So we had to put out protocol memoranda on everything from protection for the officers, how to conduct operations within our facilities, out on the street, if you will, search warrants, interviewing witnesses, suspects, and defendants. And as it continues with this Omicron, in having officers have to go remote, be quarantined because of a close contact is very disruptive to the mechanism of a task force and continuing to push forward on that information that they're receiving. I'll leave it right there.
I just want to thank you, and having served on the city council in terms of the police department, I know how important MDA is to not only our police department, but to this area in terms of its work. So thank you.
Thank you, sir.
Are there any other questions for the director? Not seeing any. I'll thank you again for being here and for putting up with the technical challenges and getting us the information you wanted to share with us. So thank you for that, sir.
Thank you, Senator.
And thank you again, Dr. Sorg, for being here. And at this point, I see we've been joined by Dr. Averill, who's going to help us understand the therapeutic potential or use currently of psilocybin, since we wanted to get a little bit more familiar with that before we consider a piece of legislation that's coming. Welcome, Dr. Averill. Thank you. Thank you for being here, and thank you for making time out of your day.
Of course. Well, thank you all so much for the opportunity to come and speak with you today. I'm really honored to be able to take a moment and certainly happy to share some information here. I know that time is short, so I will note if there are additional questions or concerns that we don't get to today, I'm happy to have a follow-up meeting, to have email communication, any of those things. So just as an introduction, I am Dr. Lynette Averill. I am an associate professor at Baylor College of Medicine and a psychologist within the VA system. Still maintain an active appointment at Yale University, as well as the National Center for PTSD, work in private practice. Also served as subject matter expert for Texas House Bill 1802, which supports a psilocybin trial for veterans with PTSD. And very importantly, as a personal note to this work, I'm also the daughter of a U.S. Marine veteran who died by suicide after years of struggling with ineffective treatments. My career really has focused on better understanding the effects of stress and trauma, both on the individual themselves who experience that, as well as the family, friends, the community at large who very much experience those things in tandem. And related to that, I think one of my areas of expertise really is looking at treatment. Not only how do we treat those symptoms for the individual, but again, when we consider the very widespread effects of mental health and mental illness, that these often, I would say these almost never, I suppose, almost exclusively have very widespread effects and sometimes intergenerational effects. So effective treatment is an incredibly critical component. I think as a field, we have come an incredibly long way in our ability to treat stress and trauma, whether we are talking about depression, anxiety, PTSD, suicidality, addiction, any of these, very common things that happen after exposure to stress and trauma. We have not, however, come nearly far enough. SSRIs, selective serotonin reuptake inhibitors, are generally the primary line of defense, if you will, the primary pharmacologic intervention for any of that spectrum of symptoms. And while they do work very well for a very small population of this, around 30% generally respond well to SSRIs. A significant challenge, though, with SSRIs, even for those individuals that they do work well for, is that they are slow-acting antidepressants, meaning that it takes weeks to months to actually get clinical benefit, which, of course, I think for any of us, if we think about really struggling with something, experiencing pain with something, being in distress over something, whether that is a physical ailment, a mental health ailment, saying, hang tight for 4 to 8 weeks and maybe you'll feel better, that's a pretty rough reality. That's a very rough reality. SSRIs have significant side effects. including cognitive impairment, significant weight loss or gain, and sexual dysfunction. So again, if we're thinking about people who are already struggling significantly with a sense of self-worth, struggling with a sense of suicidality, struggling generally with meaning and purpose, we then give them something intended to help that actually causes significant symptoms that may make things worse. There again, that's a challenge. SSRIs also really don't often target the full spectrum of symptoms. So people even who do respond often are left with symptoms that are persisting. They may have some things that shift and feel better, but other symptoms, including, importantly, suicidality, sometimes does not shift and improve. So certainly something that has been of great interest for many clinicians, many investigators, is how can we improve? What are other things that we can do to add to our toolbox, specifically for individuals who are not responding well to SSRIs, which is the majority of the population. And the majority of our, kind of average citizen does not respond well. For individuals that have perhaps more chronic problems, more severe trauma, more complicated cases, those numbers are even worse. Psychedelic medicine, so psilocybin and psilocybin-assisted treatment is very exciting for a myriad of reasons. In that psilocybin answers so many of those outstanding questions that SSRIs leave. Psilocybin works rapidly and robustly. So neurobiologically, within a number of hours, there is a very significant shift in synaptic connectivity. Synaptic connectivity is sort of this marker of brain health that seems to be underlying much of what we see in terms of symptom onset and sort of experience in stress and trauma-related concerns. This very rapid shift results in very rapid shifts in symptoms. So again, if we think about ourselves or a loved one struggling with these symptoms, the thought of having someone feel remarkably better in a number of hours or days relative to 4 to 8 weeks is incredibly exciting, and quite literally is often a life-saving sort of thought. So not only do they work rapidly and robustly, they also, in terms of the robustness, do seem to target symptoms at a much broader spectrum. And a note that I would make about this is that it is not simply the psilocybin. It is not the medicine used alone, but the psilocybin-assisted therapy. So I think that the therapy component is a very critical piece here, that these medicines are very powerful. Psilocybin is a very powerful medicine, and that the therapy component is a critical piece to the overall outcome. If you're not familiar with what psilocybin-assisted therapy looks like, it is somewhat different from our standard pharmacologic intervention and our standard talk therapy interventions, and that it is very much a combined, interwoven mix of the two, where generally patients will be very comprehensively evaluated for medical and psychiatric safety, participate in what are called preparation sessions, where there's a lot of review of what to expect in the experience, and also intentions are set. What is the goal of the therapy? What are the symptoms that we're working on? And then there is the dosing day, where the patient, of course, receives the psilocybin intervention and some sort of supportive therapy. And then there are the integration sessions, generally 2 to 3 integration sessions after a dose, that really are more standard in terms of what we may expect from psychotherapy, but really talking through what was the experience, what are things that came up, particularly, what are the things that came up that may have been sticking points, that may be deep-seated trauma, guilt, shame, demoralization, any of these sorts of things. Something else very exciting relating to psilocybin and psilocybin-assisted treatment is that this is not intended and is not rolled out as something that you would be taking every day, like SSRIs. This is generally the clinical trials that have been conducted at really premier institutions across the United States and across the world are generally doing a single dose to maybe 3 doses. And there is never, of course, a one size fits all, but many people are not needing additional follow-up care after that for quite some time, or having significantly reduced needs for other sort of mental health care and support. I know, of course, abuse liability is a concern, especially with these being Schedule I drugs included, in the Controlled Substances Act. Evidence really does not suggest that recreational abuse is a major concern. People generally, when they go through these treatments, say that the treatment was incredibly meaningful, that the treatment was perhaps some of the most significant experiences that they have had. They also note, though, that the treatment was incredibly difficult and challenging, that this is absolutely not something, that they're wanting to build into their weekend fun sort of plans, that this is really difficult work. So the addiction or abuse liability piece is really not concerning, certainly not concerning at the level that I think it has been talked about, which I think, my opinion, of course, and should have said this at the beginning, I don't think I did. All opinions are my own, not necessarily those of my employers. I do think that a lot of the concern around addiction is very much based in stigma rather than based in scientific evidence of this being a major concern. Of course, psilocybin, again, you may be familiar, is currently listed as an FDA breakthrough treatment, meaning that preliminary evidence suggests that it works better than currently available interventions. Trials are currently in phase 3, and psilocybin is expected to have FDA approval in 2025. Of course, there is an incredible amount of work to do. So certainly I very much applaud the committee for exploring psilocybin and psychedelic medicine now in kind of any shape or form that may be. I think there's a lot of infrastructure. There's a lot to be done in terms of ensuring the safe, ethical, accessible, equitable, appropriate use of these interventions. And I think there's such incredible potential for very widespread benefit. To date, of course, the majority of research has focused on major depressive disorder and end-of-life kind of anxiety concerns. There are studies, though, that are focusing on various types of addiction. Johns Hopkins has done several very impressive studies finding the effects of psilocybin in nicotine. There are some in alcohol. Some studies currently are looking at psilocybin as a treatment for cocaine use, for opioid use, these sorts of things. And again, neurobiologically, the way these interventions work, some groups, including my own research program, are also very interested in this as an intervention for, mental health symptoms associated with traumatic brain injury, both the mental health symptoms themselves as well as the actual brain injury. So I think there's an incredible amount of potential here. There are so many more things I could say, but I know we are very brief on time. So as I said, happy to address anything here in session, and then happy to have additional follow-up meetings or email communication as well. So I will stop there and answer any questions.
Thank you for all that information. You're for follow-up. I see a question from Representative Madigan.
Thank you, Mr. Chair. Thank you, Ms. Averill, for being here. I have a few questions, and if you can't answer them now, please feel free to email me or call me about them, share them with the committee. You mentioned the difficulty with SSRIs in treating PTSD. I'm wondering, does psilocybin, has there been research that indicates that it helps with the re-experiencing symptoms, which, as far as I know, I'm a licensed clinical social worker, that's often not something that typical SSRI treatment touches. And my next question is has to do with, there are some other treatments that address re-experiencing symptoms in PTSD. I believe Bessel van der Kolk's group has a lot of work on that. And I'm wondering kind of if they're studying that, because he's someone I think of that has done a lot of work, regarding trauma. And the next thing I would ask is just as far as other symptom pictures, as far as particularly post-traumatic stress disorder, some of the emotion regulation problems that are really independent of major depressive disorder or other mood disorders.
Yeah, so wonderful questions. I will try my best to answer them, and certainly we can touch base offline as well. To your question about SSRIs for PTSD and do those really touch re-experiencing and does psilocybin. To date, psilocybin has not been studied as widely specifically for PTSD. One of the things that's really exciting about the Texas House bill is that it will be among the first to really trial psilocybin for PTSD. However, there is an incredible amount of anecdotal evidence, which I think I am quite confident will translate to the more, controlled randomized trials sorts of evidence that suggests psilocybin and other psychedelic medicines really have incredible effect on the re-experiencing symptoms. Both, I think, for a number of reasons. One, again, that process neurobiologically of the very rapid and robust shift in synaptic connectivity means that there is an opportunity to really kind of restructure and reorganize our memories, our experiences, kind of the way things are connected within our brain. And of course, the way that we do that is through sort of the therapy piece, talking through things. I've had several people that I know who have had these experiences talk about the experience of the dosing and the treatment kind of being as, a hard restart on a computer, and you defrag it and then you sort of start with a kind of a clean slate. So there's that piece that I think people are really able to more carefully and deeply evaluate where some of that re-experiencing is coming from. Is that they're being triggered by certain things that perhaps with sort of a reorganization and a new perspective may not be as triggering? Are there ways to kind of reconceptualize some of those things? I think another piece is the way, again, that it works neurobiologically, that there's a lot of shifts happening potentially in terms of our fear response. PTSD, of course, is often, symptoms are often related to fear responses. Though I think another very large piece in PTSD that relates to the re-experiencing and a lot of the distress generally is that sort of sense of demoralization, whether that is specifically moral injury or just, sort of other kinds of things. The psychedelic medicines seem to really get at those things, to open a space, kind of open a foundation where, again, with appropriately trained therapists and support, that people are processing those kinds of things in a much more effective and, again, a much more rapid way than they may be. As a social worker, I'm sure you're familiar with treatments like prolonged exposure or cognitive processing, these sorts of things, even EMDR, that you may get to some of that stuff, the things that are really based in the guilt, the demoralization, the shame, the forgiveness of or lack thereof of self or others, all of these kinds of things. But it takes a good long while to get there with those interventions. And sometimes you never get there. And then, of course, you've sort of, buried the hatchet with the handle sticking out, if you will, that again, some of those symptoms are going to be better, but you haven't addressed the core of why people are really struggling. And for me, as a clinician and as someone who's been personally affected by so many of these things, as well as an investigator, that's one of the things that I think is so exciting about psilocybin and psychedelic medicine, is that it seems the opportunity for healing is so much greater than just with a standard SSRI. I have had many people personally tell me, and in more structured clinical research work I've done, many people endorsing that their experiences with psilocybin and sometimes other psychedelics have been some of the most meaningful experiences in their lives. I have never had anyone tell me that about SSRIs or about talk therapy, like never. Maybe there's those people out there. And But also I think, the way people talk about their healing, the people who do respond well, of course, not everyone responds well. I'll certainly make that note. These are not a golden bullet, not the miracle cure, not a one size fits all. Some people will not respond as well. But generally people do report feeling not only a general improvement in symptoms, but also along with that feeling kind of more connected or reconnected to themselves, more connected to other people, more connected perhaps to nature, to the divine in whatever shape or form that may take for them, where they're feeling that they have meaning and purpose. And for me, that's such an exciting piece, because I think often in medicine, in mental health care, we do an okay job at supporting people, either pharmacologically, talk therapy and support. We do an okay job at supporting people not to die. We sometimes do a very poor job, in my opinion, really supporting people to be where they truly want to live. And that's a large divide, getting a patient or a loved one, whomever it may be, getting someone to the point where they can kind of exist, tolerate existing, not be actively suicidal every day, versus feeling like that person actually values their life and wants to be living and finds meaning and purpose. And so many of the people that I have talked to, and so many of the research participants, really report that is what their experience is. To your comment about emotion regulation, I think I would say sort of similar things, that the way that the medicine works neurobiologically opens up a lot of space to kind of have some of those things shifting on a structural or functional kind of neural level. And then of course, with the assistive therapy component, I think we're able to leverage the neurobiological changes to, really do such profound, deep work in a small amount of time, so that, I think we take off so much of the weight of whatever the concerns are, that regulating emotions when they're at a 10 out of 100 is such an easier task than regulating emotions when they're at a 99.5 out of 100. And I think, just that experience of having that significant shift in symptoms, though of course there's work to do to maintain that, again, not the miracle cure, that it provides so much hope also, that knowing that you can get to that point gives a little bit more room, I think, for many people to feel like there's a bit of a release on the pressure valve there.
Thank you.
Of course.
Representative Perry.
Yes, thank you. And thank you, Dr. Averill. This has been very interesting, and I'm wondering if you could reference us any published studies that have been done on this medication, and also, by the sounds of it, treatments that should go with it besides just the medication. I would love to be able to read and do some more with that.
Yeah, absolutely. I certainly can send them. There are a myriad of papers that I can share. I have, contact information for Lucas. I know I can send them along to him, or if there's anybody else I should share those with. But absolutely, I'm happy to share. There are a lot of published papers. Again, a lot of those have focused on major depressive disorder, end of life anxiety, demoralization, and then nicotine treatment to date. Those are kind of the majority of things that have been formally published in peer-reviewed journals. And then there are, as I said, a lot of things kind of in various stages of research and development right now. But certainly I'm happy to share those documents along. And there's a couple of really good review papers as well that I'm happy to share.
Thank you.
So if those could go to Sam, I understand that he probably helped set up your being here. So
yes,
he can get it to the rest of the committee.
Yes, I do have Sam. Sorry, Sam is who I meant. I have Sam and Lucas, but yes, I'll send to Sam.
Representative Madigan, is your hands up again? Okay, All right. So, Dr. Averill, we've been asked, or we're anticipating hearing a bill that would set up some regulations around the use of psilocybin. And also it sets up a psilocybin advisory board.
Mhm.
Do you think those are reasonable next steps in a state like ours, where I'm not sure how much active research there is in psilocybin, but I don't know how national spread the studies are?
So yes, I would say I'll comment broadly on those things, as I don't know the exact language of the bill. I think to the comment of the advisory board, I think building an infrastructure now that can start really considering the issues around psilocybin and also MDMA. You know, MDMA, the committee probably knows, is another psychedelic medicine that is scheduled for FDA approval in 2023, likely. So actually, you'll be seeing that one likely before you see psilocybin in terms of a national sort of rollout and FDA approval. But absolutely, I think it is critical that both at the state and at the federal level, we really start exploring what these interventions will look like, how we're going to resource them, how we're going to train providers, certainly importantly, how we're going to pay for these. I think a major consideration is that we have to ensure that these are accessible and that these are equitable in terms of not being these interventions that we know are quite literally life-saving, but only the very elite can afford them, kind of things. I think something else very unique about psychedelic medicine that we haven't really dealt with many other drug trials and FDA approvals and things is that this is sort of a new turning of the wheel of time. These are not new medicines. These are ancient. Psilocybin especially is an ancient medicine. So there are, I think, considerations there as well that states need to be aware of and involved in terms of how do we consider or how do we protect indigenous use? How do we consider and protect, patents or these sorts of things, which is very much outside the clinical piece, but I think worth noting. From a clinical perspective, though, I think absolutely considering how to support this, because these interventions are very different in terms of their infrastructure. They kind of require a paradigm shift, at least as they are structured right now. The therapies, as I said, generally are the preparation session, the dosing session, the integration session. Ideally, the way these are set up right now, often those days include 2 therapists. So, that's a big undertaking relative to thinking about a social worker, a psychologist, a psychiatrist's time working one-on-one with a patient. It's a very different sort of workload that can be managed. And so I think, there's so many questions that need to be really carefully considered and not really easy answers. So I think absolutely having a task force that can really evaluate those things. I think importantly, I would say having a task force who does have a bit of power, if you will, to actually make some decisions, or at least really inform who the decision-making body is also a critical component. I think having also relevant expertise, of course, on the panel, people who would really understand what the challenges and limitations are, as well as what the potential benefits are. And I think that's a critical piece, that these interventions have such incredible potential for benefit. And often where there is incredible potential for benefit, there is also great potential for harm. And we, of course, want to do everything in our power to avoid harm, in all consequences, and perhaps especially so when we're talking about individuals who are already struggling with stress and trauma and these sorts of things, thinking about, how can we ensure the safe, ethical, responsible, appropriate use of these interventions? And I think a task force could be very valuable in it, helping to ensure that at a state level.
So,
and I apologize. What was the first piece? What is the first part of the
no,
bill?
it was the question that you've answered about the value of such an advisory board and some anticipated regulation. But your answer leads me to ask, are there other commonly prescribed psychotropics that are in the pipeline that maybe this needs to be a advisory board on newer psychotropics, or and not just limited to psilocybin?
Yes, yes, absolutely.
Okay.
So yes, as I mentioned, MDMA is a psychedelic medication that is also designated by the FDA as a breakthrough therapy. They're currently doing phase 3 development, have published an initial report from that was very positive, and is expected to have FDA approval next year. MDMA is very similar to psilocybin in terms of, at least the sort of general structure of how the treatment works. So the same kinds of questions that exist for psilocybin absolutely exist for MDMA. There are also other medications in the pipeline. Again, some of these not at all new, some of these, just as ancient as psilocybin, but other medications.
I almost said traditional, but then I realized non-traditional medicines, but in fact, they are very traditional.
Right. Perhaps the most traditional of all. But things like ibogaine, 5-MeO-DMT, ayahuasca are also starting to be studied in the United States. So, of course, they're much earlier in research, so we'll be farther down by the time, they get anywhere near FDA approval. But I think absolutely, not just laser focusing on psilocybin is a very wise thing, especially since it is likely you'll be having patients lined up wanting MDMA treatment in a legal medical context before they're lining up wanting psilocybin treatment after FDA approval.
Thank you for that. I appreciate that answer.
Of course.
So are there other questions of the doctor before we let her go? So I just froze. Is it my connection or is everybody?
Yeah, I'm having trouble hearing you a bit.
I think he's lost his.
I'm having trouble with my internet connection. So did you hear me, Dr. Averill?
I can hear you. It's spotty. It's kind of broken up a bit. I can hear you a bit.
To you, Representative Meyer, if you can hear me.
Yes. Thank you, Senator. So I believe what the senator was asking was for any additional questions from the committee. Seeing none, we would thank you
I'm
for
not
being here
hearing
today.
you, Representative Meyer, so it must be on my end.
I think it's on your end, Ned. Can the rest of the committee hear me?
I can,
so
yes.
Great. Well, we want to thank you, Doctor, for being here today. It was extremely informative. And we look forward to whatever literature you can send Sam's way that he'll get to the rest of the committee, and appreciate your presentation today.
Of course, very happy to. And just as a question, when is the public hearing for this? I ask because I know many people who may be wanting to submit testimony or come to that hearing.
Sam,
hasn't been scheduled yet.
Not yet scheduled, Representative.
Okay.
We can let you know when that gets scheduled so that you can line up folks that might want to participate or view the proceedings.
Okay. Fantastic. Well, thank you again so much for the time. Thanks again to all of you for your interest. I think this is an incredibly important area of work, and I applaud you for considering how to best approach this as a state. I will send some papers along to Sam. And as I said, if anybody wants to touch base additionally, I'm happy to do that. And Sam, of course, has my contact information.
Thank you. Enjoy your evening.
Thank you so much. Take care.
So that brings us to the end of our agenda for this afternoon. I would ask Sam or Anna, if she's in the background here, if there's anything else you need from us today. No? Marianne and Abigail will meet soon, shortly. It's 3:45, let's say 4 o'clock. Does that work, Sam? Yep. And then we are scheduled for a work session on 1701 at 10 o'clock tomorrow. And the committee Democrats will receive an email for a caucus at 9 tomorrow morning. So with that, I would entertain a motion to adjourn.
So moved.
Second.
And we'll see you tomorrow. Thank you very much, everyone.